Recording. Okie dokie. Let's look at our syllabus. Do you guys have me pulled up in front of you? Okay. If I share from this computer, it'll be back there. If I share from that computer, it'll be up here. So I just want to know if I should get up. I'll get up. It's okay. I don't mind. You probably didn't receive book codes yet. Oh. Oh, come on, Jessica, get it together. Okie dokie.
Are you able to turn the transcriptions on?
That's not it's not an option. It just automatically does it. I have no idea how that works. I've never had to turn it on.
Veronica,
think it's-
sometimes if you turn it off and then turn it on your end, it'll pop up for you because mine's showing right now.
Oh. This setting is managed by your company admin.
That's what my computer is saying. The company admin.
I have no idea.
You just have to go and disable your closed captioning and then turn it back on. It might work. It does that for me sometimes.
Yeah, I know. I can turn on closed captions. I can turn them off. But I can't click transcription.
It's okay. Don't worry about it. Thank you.
Sorry. Okay. So syllabus. This is 2851. Care of patients with complex health needs 1. It's 4 credit hours, 35 lecture hours. There's no lab. There's 45 clinical hours. So 80 total. Sorry, that should say 90 total. Right? 45 plus 45 is 90. Yeah. We're going to be using that big black hone-in book Your ATI is nutrition, which sucks. We are going to go over a nutrition PowerPoint today or tomorrow or Wednesday at some point. I specifically will not be testing you heavily on nutrition because you're already being tested on nutrition. Okay, so I will not really be including nutrition on my exams. Okay, you already have an ATI that you have to prepare for nutrition. I don't want to add on to it, and I don't want it taking up my points on my exam. Okay, so please make sure that you study adequately for your nutrition ATI, your proctored ATI. Make sure you're doing your dynamic quizzing. Make sure you're doing your engaged pharmacology and your flashcards that you get through there. Okay. Because like usual, your ATI is worth 10% of your grade, right? So make sure you prepare for it. All right. Next month will be med surge, the proctored med surge. Okay. So this just says that our first and second exam are 25% of your grade. The final is 35%. Lippincott, which is, like I said, you have 2 VSIMs that are assignments, okay? You do not have to do a clinical packet. I'm going to say that again. You do not have to do a clinical packet for the assignment. Now, if you have a VSIM for clinical hours, then that's obviously different, okay? But for the assignment, you do not have to do a packet for these. So for these, they're worth 400 points. And I'm going to be really honest with you guys. I myself have done VSIMs, and I would rather you like go in, mess around, do like a bunch of stuff in there, than only do it just to get a perfect score. Because that's just wasting your time. And it's not giving you what you need out of the experience, right? Even when I go in there and like do it and I do the things that I think should be done, and if it's out of the order that they want it in, then they dock you points on it, right? It's really dumb. I don't think VSIMs are dumb. I think they're a very, very good experience. Let me be clear. I think the VSIMs are a very good experience when you do what you're supposed to do in there, when you look at it as a learning experience and opportunity. When you look at it as like, I just need to get this done as fast as possible and I don't care about this and I'm not learning anything from it, then yeah, that sucks, right? But I can't change your perspective. You are the one with the perspective when it comes to these experiences, okay? So I also have come to terms that I refuse to fail someone for a VSIM that I can't even get 100% on. Okay, the only way you're getting 100% on this VSIM is if you look it up online or Quizlet or TikTok or whatever, you follow the exact steps that you're going to have to take to get 100%. Okay, I don't care about your 100% on the VSIM. I want you to actually go in there and have the experience. You hear what I'm saying? Okay, so please don't turn in a VSIM that you spent 3.3 seconds on the simulation and got 100%. I would rather see that you submitted a VSIM that you spent an hour on, that you played with it and did blah, 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 and had this experience, and you got a 65%. Okay, am I going to give you a 65%? No, I'm not. Because like I just said, I used to fail someone over a VSIM. Okay, so when you do the VSIM, there's 4 parts. There's the pre-quiz, the simulation, the SBAR, and the post-quiz. All 4 of those you have to submit to Brightspace. Okay, you can do the VSIM multiple times. Now on the syllabus, it says that Whatever points you get is what I'm going to give you. So if you get 285 points out of 400, you're getting 285 points out of 400. I just told you I don't want to do that. Okay? You put in the effort, you have a good experience, I'll give you the points. Yes? Yes. Perfect. If you want to do it again, do it again. Yeah.
So like what's the cutoff? Because I think before like they wouldn't accept anything below a 80%.
I think it is. I think the cutoff is an 80%. I just like specifically, it's next month. There's one, his name is Skylar Hansen. I'm not kidding you. I personally did that Skylar Hansen VSIM like 5 times and saved his life every time. I saved his life every time. And don't you know, I never got 100%. Never, not one time. Nope, but I saved his life. Okay? Which is why I'm telling you that it's the point system is poopy. Okay? And it's all about learning how to take care of the patient and doing what you need to do, prioritizing, looking at the feedback that it gives you. Do you need an 80% in order to pass the VSIM? Yes, I think you do. Okay. And like I said, you can do it more than once. So the first time you do it, are you going to bomb it? Probably. Probably. But that's okay. Next time, after you have your experience, then go look it up on TikTok to see how to beat it. Okay? But try the first time without other resources. Does that make sense? You understand what I'm saying? Yes. Okay. All right. Anyways, we have ATI video case studies. These are also worth 2.5%. The nutrition ones. There's 2. There's one that's like enteral, and there's another one that is TPN. You have to do both. Okay? Right? I think there was a typo or something, because I feel it's all coming back to me. But there are 2 nutrition ones, and you have to do both of them. Okay, I think one of them is like a TPN, and the other one is like G tubes and such. Okay, and then of course we have our ATI. You have your practice A, practice B, and then your proctored nutrition at the end. Okay. You guys experienced the new math protocol? What's the feedback? Do you like it? Do you hate it?
Like doing it on the API, like learning it on the API?
No, not the math modules.
It doesn't make sense.
Not the math modules,
That's
the
so
ones that you
dislike
don't
it.
I think
take
last
them.
month was kind of annoying because we took the quiz on Brightspace for like our, the math like pre-test thing. And then she said, okay, now you have to screenshot that and upload it to Brightspace. I'm like, girl, it's already there. So then we had to screenshot that, upload that to Brightspace, and then we had to print that out and take that with us to campus, and then nobody even looked at it. So the exam. That was like redundant as hell. It's not gonna lie.
That's kind of silly. I'm not gonna make you do that. I can already see that you did it. I don't need you to upload it and print it and do all the blah, blah, blah. Believe me, if you didn't do it, I'm going to tell the proctor that you can't sit for your math test. So you don't have to do any of it. You don't have to do any of that.
I get 100 because we were required to get 100, but they didn't tell us to like after I took the test several times.
Are you talking about the module or are you talking about the math
Yes,
test?
the module. Like after we took
The
it, then
module, I believe you have to get a 90% on the module.
okay, because
It says it on here somewhere.
okay.
Hold on.
It does kind of suck to drive to campus 2 times in 1 week to go take one test that takes like 10 minutes. So it's
Yeah.
kind of like inconvenience in a way.
What I will say that it did show huge, and I'm not kidding, huge improvements on the pass rates. Like so many more people passed.
I believe it. I think it was very
Yeah.
helpful.
I do
Yeah,
like
I
because
think
taking it.
that if we were just also allowed to take our math prior to the exam, that would also help. Because then you get your exam score and you're either like okay with it or happy or bummed, and then you have to go take a math. But if you did your math first, I feel like it would get it out the way, and then your exam's your exam.
right. Yeah, I feel like when you
If you fail the math, then that's going to be on your.
math ticket to test. Is that in week 1? Yeah. Oh, here, no, it's week 1. Ah, here we go. Okay, so you are going to do the critical care medications, complete the test. You must achieve at least an 80%. You do, I mean, just take a screenshot and upload that to me because you have to prove that you passed your module. And I mean, we did this in advanced farm. I am not chasing after everybody every day to go into ATI, go into Lippincott, make sure you did your assignments. Absolutely not. Okay. If you want credit for your stuff, you turn it in on Brightspace. Okay. Please. Your girl does not have time. All right. So, this is your ticket to take the math test. It's due the day before your first exam, which that doesn't make sense anymore because it's not after the exam. So your first math test is when? Thursday or Wednesday? I'm sorry.
Yeah,
So
it's
we'll be
Wednesday
covering
after
what
lecture.
that's going to be on this test on Wednesday that we supposed to go
Hold
over
on.
in 2 days.
Hold on, there's too many people talking. The math exam is at 2:30. That is a little hooey, isn't it? Yeah, it doesn't give you a lot of time to do the module, huh? Because at least for advanced farm, we didn't have a module. So all they had to do was take the like math worksheet, like a practice worksheet, and that was their ticket to test or whatever.
That's what we had last month too. It was just a little like test in Brightspace. It wasn't a module for mental health.
Yeah. Um, hmm.
Is there like
I don't know if
new
you heard my
math with the
question or
critical
not, but is
care?
it new math?
Yeah.
So no, it's not new math. It's let's look at the remediation. Oh, the module is the remediation. Oh wait, no, here we go. Oh yeah, it is. Okay. So the critical care math, I think it has like a little bit of everything. There's like milliliters per hour, drops per minute. I don't know if I'm sure there's weight stuff on there. Everything that's in the module is on the test. Like if you don't do the module, the module literally prepares you for the test. Calculating, is that what it says on ATI? So calculating flow rates, continuous IV medications, so milliliters per hour. Oh, titrating. So, and we're gonna do a practice one today. We're gonna do a practice thing. So there's a question where the first part of the question says you're giving X amount, for, find the milliliters per hour. And then the next part of the question is the dose has increased to 90. What is now the milliliter per hour? Kind of like Pitocin, yeah, like titrating medications.
Yeah, so like.
hour, half an hour, whatever.
It's titration. It's the same idea. Titration can be done in different ways. It can be done per order. It can be done, well, it's always in order. Like when you titrate like pressors or Pitocin, like you're titrating for a goal. Okay. So like when it's pressors, you're titrating for a goal of a MAP greater than 65. And with Pitocin, you're looking at contractions and you're looking at whatever. So when you titrate medications, it's really just titrating the dose when you go up and down. Okay. Like I said, we're going to do some practice questions today because I want us all to be successful. Okay. This is the VSIM thing. I told you it was worth 400 points. This says first attempt. I'm not holding you to that, especially for like, I had a class that they had never done a VSIM before in their lives. And their first attempt, I mean, they literally had no idea what they were doing. And they scored so poorly because of that. I'm not going to hold. No, absolutely not. Okay. We're not pros. I mean, maybe some people at some campuses are pros at VSIPs. I am not. North Canton probably is not because you guys haven't done a lot. Niles doesn't do a ton. So like I said, put in the effort. If you want to do it again, you can do it again and you'll get the points. Okay. ATI, the case study is worth 50 points. The post test, the point system is right here, so it's a 50-50 thing. With the practice A and B with the and the proctor at the end, you know that changed a couple months ago. A and B are complete versus incomplete, so if you do it, you get a complete. The proctored exam is 100 points. If you get a level 1, it's 70 out of 100. If you get a level 2, it's 85 out of 100. If you get a level 3, it's 100 out of 100. If you get below a level 1, it's 55 points. Okay, so obviously that would hurt you significantly. Okay. Any questions on the syllabus?
I do have a question about the practice A and B. I had you for another
Yeah.
class. I forget which one it was, but it was a thing where you didn't want us to necessarily like use the books or outside resources. Are we
Oh,
allowed to do that, or should we just take
That's a
the
wonderful point.
practice?
So,
Okay.
thank you so much for bringing that up because I would have gotten mad when next week rolled around. So, when it comes to practice A and B, do not submit to me something in the 80s, 90s percentile. Okay? I already know you cheated. I already know. Okay? So, if you are going to use outside sources, that is fine. But you better tell me what sources that you used. If you're going to put in a 90% and you upload a remediation that is 1 page long with 3 topics, first of all, you're not doing yourself any service whatsoever. Okay? If you are using outside sources, I want you to be taking notes while you're using those outside sources.
We're supposed to remediate off of our first attempt.
Well, people still cheat on their first attempt.
Right, but I was just, because I know before people have taken it multiple times.
You can take it multiple times. So, yes, you should remediate off of your first attempt. So, you take the practice test. You get a normal score, which is anywhere, and I'm not kidding, anywhere from a 50 to 70% is normal on a practice test. Okay? You do the remediation. If you want to use outside sources while you're taking that first attempt, because I'm not stupid, I know that you all do it and it's okay, but you better cite your sources and give me your notes. This is the only way that you are going to learn and grow. If you just do these practice tests just to get them over with, you're not learning anything, you're going to bomb that proctored exam and it will probably cause you to fail this class. I don't want that for you. I'm not here to make your life harder. I'm trying to help you. And this is the only way that I can help you and still allow you to use outside sources, because a lot of people do. Okay? Am I clear? Does anybody have questions about that?
Miss Simmons, how do
Yes.
you how can you okay, so a level 2 on the proctor. How would you suggest us to study to get a level 2 on the actual proctor?
Sure. So dynamic quizzes are wonderful. You should be doing dynamic quizzes often. I don't know how often, to be honest. You guys have more experience with dynamic quizzing than I do. But also, do you guys have the pharmacology engage? Is it part of your ATI where you can go? Dynamic quizzing helps a lot. I've always gotten a level 2. Yeah.
Yes.
You do have the engage. So if you go under like engage pharmacology, they have a ton of flashcards, and you can do flashcards specific to the ATI practice nutrition test, A or B. Okay. So also you have an entire nutrition ATI book. It's not large. I mean, it's literally like this thin. It's very small. I think maybe it's over 100 pages, not even. So use your resources. Everything that they test you on is in that book. Do the questions at the end of each section. And that's the best way I know to tell you. You have to put in the work.
Yeah, okay,
Okay.
thank you. I was just wondering if you had like any extra tips or anything that I wasn't
I
doing, but
wish.
no, it's okay. Thank you.
I wish I did. There's also
What
a
if
standard quiz.
what if
Go
we're
ahead.
able to get higher than a 70% without looking up anything?
I love that for you. I love
Because
that for you.
I haven't done it before, but I've actually been sitting here reading the nutrition ATI book the last few days.
I think that's wonderful. I'm talking about like it probably like an 85 or higher is unnatural for a student to be able to achieve with, especially on the practice. Am I saying it's impossible? Absolutely not. I'm only saying that it's unlikely. And it's not a knock on you. It's not a knock on anybody. I just want to make sure that you're prepared when your proctor exam comes. Okay? Does that make sense? Okay.
I have a question.
Yeah.
Can you elaborate on the case studies? Because we haven't had really any of them.
The video case study things.
Yep.
That's a great question.
I think
don't
we
think
have
they
one
take
of those, and I think it was a while ago. And it was actually, we did. It was like over diabetes, and it was giving this kid insulin or something. But we didn't really get a lot of feedback on it, so we don't really know how we did. Like there was like a spot where it said like your instructor will review it and give feedback, and then she never did. But that was like in med surge. That was like a while ago.
Yeah. I think there's a video. Let's go into ATI. These are the flashcards right here. Active stack pharmacology flashcards. Or yes, or I just got my brain is still in advanced pharmacology. I'm sorry. Oh, Video case studies. So you have to do dementia and delirium is one. So it looks like there's a 5-minute video. And then it looks like you write a response. Is that really it?
And then, yeah, you take the.
And then there's a quiz.
No, there's no quiz to it. It just gives you like you give your response and then like the expert answer is like what, ATI would have said.
It grades
And
it.
then we're supposed to get
There's a quiz outside
it
of
doesn't
that.
grade it, no.
There's
It
should be, no, there's a quiz because half of the grade is a quiz.
Yeah, the quiz is after.
Yeah, because it says for the grade, it says there's a post-test score. So there has to be a quiz afterwards. Oh, okay. If you go out of here. It says there's the test right here. Okay. All right, course calendar. So week 1, we're going to start with fluid and electrolyte balance, acid-base balance, IV therapy, blood components, and then there's a small PowerPoint on nutrition. Like I said, I'm not spending a ton of time on nutrition. I'm not testing a lot on nutrition because you are already going to be spending so much time on nutrition. Okay. By Sunday, which is the 8th, I believe. Yes, the 8th. You have 1, 2, 3, 4, 5 case studies and your ATI dose. So I need to ask if that's due by Wednesday. I mean, I would assume so. I would assume that the ATI module would be due before Wednesday when you have to take your math test, because how else are you going to prepare for your math test? Unless you do the module, right? So I would probably work on your math module today. Week 2 is going to be complex neurological overview, procedures, increased intracranial pressure with drains, hospital-acquired delirium versus dementia, brain tumors, TBI, and spinal cord injuries. I believe, yeah, that next week is the 15th. So your ATI case study, dementia and delirium, the first Lippincott VSIM, which is Brandon Sharp, and then your practice exam A, those are due by the 15th at midnight. Okay.
I don't know if it's the same for everybody, but just so you're aware, we've already done Brandon Sharp VSIM. At least my group has.
Of course.
We did Skylar Hansen too.
Oh, I hate Skylar Hansen. Ugh.
I mean, I'm okay with doing it again. I just might get
Hey,
that
it might
higher
just be
score
an
on
easy
it.
grade for you, girl. It's just gonna be an easy grade for you. That's fine. It is what it is. Like I said, it's an assignment. It matters most when we're talking about clinical hours. You don't want to have to redo VSIMs when we're talking about clinical hours, because that's not great. You want to have a new clinical experience, new VSIM for every clinical hour that you have to do it for. This is an assignment, so I'm putting it in a different category. If you've already done it, good on you, and I hope you do better on it. All right, week 3, we have complex endocrine, hypoglycemia and hyperglycemia, DKA and HHNS, DI versus SIADH. We talked about a lot of these in advanced pharm, hormone function, thyroid storm. So I'm hoping that the only new thing that you're going to have in week 3 that we and all of you have not talked about is DK and HHNS. Okay? Because we didn't go into that in advanced farm. Do I expect you to remember everything? No. Of course.
Said you said this.
It's on there. I think.
Well, it's on there, but work.
Oh, I think I might have fell asleep. It'll be on there. All right. Week 3. So that will be everything is due on the 22nd. So that's going to be the dreaded Skylar Hansen. You can't pass Skylar Hansen. It's okay. I hear you. Can't either. I don't know what I'm doing wrong. I save his life. I don't understand why he's so difficult. I never get orders. At no point do they ever give me orders for D50, but I have to give him D50 to save his life. There you go. There's the answer. You're not going to get 100% though, because I don't know how, they won't give me the orders. And then your practice B is due on the 22nd. Okay. And then that last week, we have class on Monday with your ATI to follow. If you remember, I like to do a review on that last day, on that last lecture day. Hopefully we get through all of our stuff so we can do a review that day. And then your ATI will be to follow. And then the final is on drive. I think it's Wednesday, but I just want to make sure. Our final is on Wednesday at 12:30. Okay. Does anybody have any questions about their schedule? Okay, so we have class Monday, Wednesday. Most of you have clinical on Thursday, Friday. Okay, so Canton, Thursday, Friday. Niles, Thursday, Friday. Niles B, you have a random the first 2 Tuesdays. Make sure you look at that. Illyria, Thursday, Friday. Sylvania A and B, your guys is a little different too. Cincinnati and Dayton are both Thursday, Friday. Please make sure you know where you're supposed to be. Okay? And if you have any questions about your schedule, please ask.
Yes, so for now, we have that visa. Is it online or is like, do we have to be like on ring with somebody or are we going to our campus? Because it doesn't say on the schedule.
So I think it said Amy Freight. For Niles, yeah. So Amy Freight lives in Florida. So I would assume that it's going to be at home on Ring Central. Amy also, or Dr. Freight, by the way, Dr. Freight, usually reaches out like the day before and sends an email to your group and gives you instructions and her Ring Central link and gives very, very clear instructions on her expectations of your VSIM. So it will absolutely be online. I'm assuming at home unless Missy says otherwise, which I don't believe she will because we didn't talk about that. So yeah.
I have a question about tomorrow's
Okay,
recent
thank you.
breath in Niles.
Tomorrow?
Yeah, we have one tomorrow.
Okay.
For the B
Clinical?
group or whatever in Niles.
Uh-huh.
I have something like will they let if I need to like leave out for like an hour, is that gonna be a problem?
Yes. These are clinical hours. These
Okay.
clinical hours are required by the Ohio Board of Nursing, and you must be there the entire time.
Okay.
Okay. Any other questions? Yeah.
Can you guys stop sending like the address of the clinical site? Because
that would be ideal.
My address is not used to.
Oh, where'd you go?
It was like the middle of nowhere.
What was the site?
It was hard.
Oh.
So I had to use like Google Maps and then take the trip apart when I have
Oh. Yeah, we usually put the addresses on there. I don't know why it wasn't. I'm sorry. For UH?
Yeah.
So it's UH Portage, which is in Ravenna. You guys have all been to UH, yes?
Yeah, one.
And you have your badges?
Yes.
Okay. Why?
Amber took ours.
I thought you got them back.
She didn't have it. She was in.
Oh, can you go see Amber today? Okay. Because we might have to send an email over to them. And have either them reprint it or I don't know. I have no idea. But we'll figure it out. But make sure you handle it today. Okay. What was I just doing?
Jessica, I sent you a
The
couple
address.
personal messages. If whenever
Yes,
you get a
ma'am.
second, if you can address them.
Okay. Address them right here, right now, or address them later?
No, you can whenever you get a second, you can message me back. I just didn't know if you had seen them or not.
Okay. I saw the first message. The answer is yes. Yeah. So you'll have to actually reach out to Terry about that. Because that will have to be like approved with like Terry and stuff.
Okay.
That makes sense. You're welcome. UH Portage is 6847 North Chestnut Street.
You sent that our group chat.
There you go.
Yeah.
6847. She said, am I in that group chat? I hope so. There's only 5 of you. Don't be counting around. Jeez, these girls are vicious. 6847 North Chestnut Street, Ravenna, Ohio. 44266. You could also look it up and send a pin. No. All right. Any other questions?
Yes, sorry. So you know how when we had events from a couple of months ago and you really used email like heavily, like the group email, will you be doing that again?
Yes, ma'am. Yes, ma'am, I will be. That is my form of communication with all of you. Any other questions? Yeah.
What about like reviews?
Hold on one second.
You want us to screenshot in our grade book?
Sure.
And then send that?
Yeah, that's fine. Some people do it, they'll take a picture of each individual thing and then upload like 4, I don't care how you do it, as long as it shows you did all 4. All right, go ahead. What were you saying?
Will you do like reviews or study guides?
We are not allowed to say the word study guide. Who was that? Who was that?
I
Tell me
don't
who it
know.
is. She said, I don't know who it is. Remember, we're not allowed to say the word study guide. Jessica gets in trouble for that. We do key points. Remember key points?
Yes.
Yes. I do key points. I used to give out a point for them, but I'm not allowed to do that anymore, which really just grinds my gears. I don't know if you guys ever key points and zebras, baby. That's right, Marissa. Key points and zebras. That's what it's all about.
Mrs. Simmons,
Yes.
while like we're doing lecture, you'll be like, "Oh, I have a star. Write this down." Do you still do that?
Yeah, girl. Of course.
Okay.
What do you think
That's
I
what
just changed
so
overnight? What do you think I'm just a whole different person than I was 3 months ago? No, I'm just kidding. I'm just giving you a hard time. All right, I have to pee. Let's take a break. 10 minutes, no more. And let's go take a potty break. I'll be right back. And then we're going to start with content. Okay? Agreed. Okie dokie. So, would you like to start with nutrition or end with nutrition? Either way, we have to do it. 'Tis my nemesis.
Start.
Ugh. Okay.
Either
Fine.
one.
As long as we have time at the end for math.
Make sure you remind me. We're here till 2:30. So, at least either by 1:45 at the latest 2:00, we have to start math. Okay. All right, let's get nutrition over with. Welcome. Okie dokie. All right, are we ready? Okay, so nutrition is understanding the role of basic nutrients, which provides the foundation for selecting foods that promote good health. We have multiple different ways to classify nutrition. The first way is through inorganic, organic, and energy. And then that breaks down even farther. Okay, so your inorganic is going to be your water and minerals. Organic includes inorganic is water. Organic is minerals and vitamins. My bad. The way that these arrows look is a little misleading because of the colors. So inorganic is water. Organic is minerals and vitamins. And those are your micronutrients. And then your energy nutrients, which a lot of people refer to as macros, are your carbohydrates, your proteins, and your lipids, aka fat. These are your macronutrients. If you ever follow a macro diet, all my diet girlies out there, this is our Roman Empire. My nemesis, macronutrients. You want to have lots of protein, you want to have not so many carbs, and even less fat. They take all the fun away from us. Okay. But it's important to know that minerals and vitamins are micronutrients. Most of them are essential. And our macronutrients are essential. Okay. You should not have any of them at 0. It's not very sustainable. So, inorganic, the role is for chemical reaction, transportation, body temperature regulation, promotes bone formation, conduct nerve impulses. This is your water, right? See, I really need to.
Minerals, I'm sorry, minerals are also inorganic.
Girl, I literally was just looking at that and being like, wait a second. You know I hate when this happens. I hate it. I hate saying things that are wrong. I hate going back. But at least it happened right in the beginning and not later on with something more important. Right?
I say on the
It's extremely important. But is the fact that minerals are inorganic, is that the most important thing you're gonna learn today? No. No. I pray that this is the only time that I have to backtrack today. And this is not going to set the vibe. Okay, so rewind. Okay, so inorganic, water and minerals. They have chemical reaction. They're responsible for transportation, body temperature regulation, promotes bone formation, and conduct nerve impulses. Okay, organic, vitamins. They build and maintain body tissue, regulate the body processes. This is where your electrolytes live. And then energy, your macronutrients release energy for maintenance of homeostasis. A healthy eating pattern includes food that provide all essential nutrients and allows a broad assortment of food sources so that we're not deficient in anything. Okay. Water is the most abundant. It's 70% of adults, 77% in infants and children. It is the major component of body fluid. I mean, I feel like we all know that by this point. So when we're talking about input or intake, drinking, food, fluid resuscitation, any IV therapy, which is the same thing, and then output, which is urination, defecation, sweating, crying, any type of fluid leakage from anywhere. Okay. When we talk about micronutrients, we have different types of vitamins. We talked about this a little bit in Advanced Farm when we talked about water soluble versus fat soluble. Okay. The most important thing about water versus fat soluble vitamins is that fat soluble, you can become toxic. You can basically overdose on fat soluble vitamins. Your fat soluble vitamins are A, D, E, K. They need fat for proper absorption. So if you have no fat or taking a medication like bile acid sequestrants that bind to fat, then you're going to be deficient in your fat soluble vitamins. Does that make sense? Now, if you take too much of water soluble vitamins, then you just pee it out. Your body says, okay, I've had enough B12. and then you pee the rest out for the rest of the day. Okay? So, water soluble, if you take too much, you pee out the excess. Fat soluble, if you take too much, you become toxic. Okay? So, our water soluble vitamins are all of our B vitamins. B1 is thiamine, B2 is riboflavin, B3 is niacin, B6 is pyridoxine, B9 folic acid, B12 cobalamin, and then vitamin C. So each one of them have different things that happen with deficiency. Wernicke-Korsakoff syndrome is common in people that abuse alcohol. Because alcohol stops or inhibits the absorption of thiamine. So we then, if you abuse alcohol, you then become deficient, which causes the Wernicke-Korsakoff syndrome. I actually do not know what beriberi is. I'm gonna have to look that up. Beriberi is a disease caused by a deficiency of thiamine that primarily affects the nervous and cardiovascular system. It is rare in developed countries like the US due to vitamin-enriched foods, but can occur in individuals with alcohol use disorder or specific dietary habits. So both of these are common in alcohol abuse because the alcohol inhibits the thiamine absorption. B2, a lot of people that are deficient, you see they have like cracks in the corners of their mouth over here. Dry, swollen lips. B3, if you've ever, so back in the day, my brother used to get drug tested when he was a teenager because he started smoking the Mary Jane and my parents were not happy about it. So he used to get drug tested every week. And he read about niacin, and if you take a ton of niacin, it'll clean out your system. Well, he didn't know that a side effect of niacin is severe flushing. So this dude, and itching, by the way, this dude turned cherry red. His skin turned cherry red. He was so itchy, and we thought we had to take him to the hospital. I'm not kidding. It was ridiculous. Now they have a formulation that is non-flushing niacin. I don't know what they did to it to change it. But so niacin can cause diarrhea, dermatitis, which is the itching, redness, flushing, irritation of the skin, and apparently also dementia. So it's important to know that niacin causes flushing. B6, if you are deficient in B6, then you have a specific type of anemia. And you need B6 to solve your anemia. The same thing with B9 and B12. So B9 is megaloblastic anemia and B12 is pernicious anemia. The anemia is caused by the deficiency. If you want to fix the anemia, you have to treat the deficiency. Okay? Vitamin C, you have swollen and bleeding gums, tooth loss, bruising, and weakness. Also, what was that pyrite disease that's coming back? People are all of a sudden
scurvy.
Scurvy. Yes. People are all of a sudden getting diagnosed with scurvy again because they're not getting enough vitamin C. And it's funny because like I saw these TikToks where it was saying like the only time that I ever even knew about scurvy was when I did that project in middle school where I was like the captain of the pirate ship and half my people died because I didn't bring oranges on the voyage. You guys remember that? Did you do that? No. I feel like it was a very common thing. Okay. Over to the fat soluble. Your vitamin A is responsible for vision, immune function, and cell growth. We get it from oranges, yellow vegetables and fruits, dairy, and fish. If you are deficient, the most common thing that it causes is night blindness. Vitamin D, you must have vitamin D for calcium absorption. If you don't have vitamin D and you can't absorb calcium, then you inhibit bone growth. See how that works? It also affects your immune function. So we get this, we don't get vitamin D from the sun. The sun helps us absorb the vitamin D that we have taken into our bodies. Okay? Fatty fish, fortified foods, and eggs. If you're deficient, you can have rickets or osteomalacia. Vitamin E, this helps with antioxidants, protects the cells and the immune function. We find vitamin E in leafy greens, seeds, nuts, vegetable oils, and those little vitamin E capsules. My mom used to rub them all over her face. If you're deficient, it can cause anemia and ataxia. Ataxia is a neurological sign indicating lack of muscle coordination, often caused by cerebellum damage. So you can have gait abnormalities, slurred speech, tremors, and poor coordination. Vitamin K, this has a lot to do with your blood clotting, bone maintenance, tissue health. What is vitamin K the antidote for? Huh?
Warfarin.
Warfarin. What is the antidote for heparin? What?
Vitamin K.
Protamine sulfate. Protamine sulfate. Vitamin K, warfarin, heparin, protamine sulfate. Put it in your filing cabinet. Do not forget it. We find vitamin K in leafy greens, soybeans, beef liver, eggs. Deficiency can cause an increased risk of bleeding. So here's the thing about this content and how the questions are asked. A lot of the time it's going to say, this patient this patient is symptomatic of pernicious anemia, or yes, pernicious anemia. Which vitamin is essential for the deficiency of this type of anemia? And then you have to be able to say, oh, that's cobalamin, B12, okay? Or what type of food does a person deficient in vitamin D need to eat? Is it A, orange vegetables? Is it B, leafy greens? Is it C, nuts? Or is it D, eggs? Ha, it's eggs. Okay, so that's kind of why I have a love-hate relationship with nutrition, because I feel like it's just a lot. It's like a large subject that you don't think about, like really diving deep into. Like, for example, what food has the most potassium? Say bananas. I dare you. I dare you to say
Potatoes.
Potatoes. It's a baked potato. A baked potato has so much more potassium than a banana. Okay? So it's little things like that that they like to try to get you on when it comes to nutrition questions. Require fats to be absorbed. There's a higher risk of toxicity because they're stored in fat, the fat soluble vitamins. So it goes both ways with deficiency and toxicity. Micronutrients. This is where we start talking about our electrolytes. Inorganic molecules that aid in hormone and enzyme production. They are essential for cardiac, neuro, bone, and muscle functioning. We know this because how long have we been talking about sodium, potassium, calcium? We've been talking about them for so long. Potassium is necessary for cardiac function. Sodium is necessary for muscle contraction, nerve impulses, for fluid volume. Okay? So, this really, especially the macro minerals, the electrolytes, should be a refresher for you other than the magnesium and phosphate because we haven't touched on those much. So sodium we need for fluid volume, muscle contraction, nerve impulses. We find this in salt, obviously, because it's sodium. For potassium, it is essential for cardiac function, muscle contraction, fluid volume. Again, fluid volume, why? Because there's a sodium and potassium pump. They are teeter-totters. If one affects fluid volume, so does the other, okay? We find this in bananas, potatoes, avocados, beans. I would think that it's necessary for you to know what are the things that you can find potassium in. Can I be clear?
Strawberries.
I'm saying in the future, I need you to know where you can find potassium, in what foods. Calcium, it's essential for bone health, blood clotting, muscle contraction. When we go into cardiac next month, and especially when we talked about calcium channel blockers 3 months ago, we realize how important calcium is for cardiac conduction. It's extremely important. So we find this in leafy greens, soybeans, dairy, fish, orange juice. Magnesium, this helps with magnesium relaxation is what I just tried to say. Muscle relaxation, nerve function, heart contractility. We find this in chocolate, specifically nuts, leafy greens, whole grains. I'm never going to be deficient in magnesium. I love chocolate. I love it. Even I love dark chocolate, sometimes more than milk chocolate. Phosphate is essential for bone formation, energy metabolism, nerve function. We find this in meat, fish, dairy, pumpkin. Pumpkin. Interesting. So then we have our trace minerals. Iron. This is an essential part of your hemoglobin. Okay. If you are deficient in iron, you have a reduced oxygen carrying capability. It all comes back to oxygenation. Everything in the world, everything in the human body comes back to oxygenation. Okay. And if we are missing an essential part, we are then going to affect our oxygen carrying capability. Okay. Zinc, this helps support our immune system and metabolic function. This can be found in shellfish, meat, poultry, legumes. Iodine is 100% essential for thyroid function and metabolism. This can be found in seaweed, seafood, and iodized salt. This is why all of our salt is iodized. Okay, our table salt. Pretty sure they put it in our water too. They also put fluoride in our water. This prevents dental caries and decay. You can find it in toothpaste, fluoridated water. grapes and raisins. Chloride helps in fluid balance and acid-base imbalance. That's going to be important when we talk about our next subject, which is acid-base balance. And this is in table salt, whole grains, and tomatoes. Copper helps with red blood cells and collagen production, can be found in beef liver, oysters, mushrooms. By the way, have you heard about all the people dying from oysters? Vibrio. There's like a parasite that can live on oysters, and if you eat them raw, it'll kill you. I'm not going to be eating oysters. No, thank you. Selenium, this is an antioxidant and or it helps with antioxidant and thyroid metabolism, can be found in Brazil nuts, beef and pork, and seafoods. So our macros, we have carbohydrates, proteins, and fats. You see how fats has more calories per gram? That's because it hates us. Okay, they're heavier. Carbohydrates and protein both have 4 calories per 1 gram. Fats have 9 calories per 1 gram. That's why we need less fat, because it's a heavier molecule. Heavier, and I mean that by caloric intake. So the recommended intake of carbohydrates is 45 to 65%, which I feel like is a bit excessive. They just like to keep us fat, and they want to make us all diabetics so that they can make all of the money. Just say, we do live in the beautiful America. Protein should be 10 to 35% of your total calories per day. Proteins are, we have essential proteins and unessential proteins. You have to meet all of your essential proteins, which are amino acids, in order for your body to function normally. This is also a very common question type. If your patient is a vegetarian, what 2 types of protein source can they put together so that they meet all of their essential proteins? Make sure you look into that. Killer question. Fats help with energy storage, insulation, obviously insulation, and protection and absorption of fat-soluble vitamins. This is 20 to 35% of your total calories. There's good fats, there's bad fats, there's really bad fats. So carbs, ouch. You have simple carbs versus complex carbs. Simple carbs are easily digested. They provide quick energy, and they cause a spike in glucose. And they can be found in honey, fruits, milk. You have monosaccharides versus disaccharides. Mono meaning 1, so 1 molecule. Di meaning 2, which contain 2 of the molecules. So you have over here for the monosaccharides, we have glucose, fructose, galactose. And then with the disaccharides, these are the ones that are found in sweets and candy, beer, dairy products. This is your sucrose, lactose, and maltose. Do you need to know all of that for me? Absolutely not. Hell no. Absolutely not. Do I want you to know that there's a difference between simple carbohydrates and complex carbohydrates, especially for diabetics, specifically type 1 diabetics, specifically, because then we're talking about glycemic index. We're talking about insulin resistance and insulin spikes, right? The higher the glycemic index, the faster the insulin is going to spike, the faster that patient can become hypoglycemic. Okay, so that's when that stuff becomes really important to me in complex care. All right, so complex carbs, they take longer to digest. They provide longer sustained energy. They cause blood sugar to rise slowly at a steady pace. So you don't have this huge influx of insulin because of this huge spike in blood sugar, right? Our insulin gets put out from the pancreas to our body because of a spike in glucose in the blood serum. If it's a steady state, then it's a steady response. If it's a large spike, it's a big response. Okay? So we have polysaccharides, poly meaning many, and they contain many or multiple sugar molecules. And this is your glycogen. Where does your glycogen live?
In your muscles?
No. It says it right
In
here.
your cells.
Glycogen is stored in the liver. Oh, it does say muscles, but specifically, most is stored in the liver, later released into the bloodstream through a process called glycolysis. I want you to know that. Glycolysis is extremely important. We're going to talk about it next week when we talk about DKA, HHNS, diabetes, everything that has to do with it. Okay? So, when our bodies are hypoglycemic or fight or flight, and your first instinct when I'm standing in the forest and there's a bear staring at me, and I'm like, okay, I'm gonna die. My fight or flight response kicks in. Do you think my brain is gonna say, hey, you should eat a candy bar? We need some energy. No. It's gonna say, hey, liver, give me some sugar. Okay? The liver is going to process its stored glycogen in the process of glycolysis to put glucose back into the bloodstream so that we can have metabolic energy to fight the bear. Okay? Or man or bear. Always going to choose bear. Okay? So then we have our fiber, which is a complex carbohydrate that's not absorbed by the body. We have soluble versus insoluble. Soluble dissolves, insoluble does not. So fiber is very, very good for us. It's good for the stool. It's good for your digestion. Soluble attracts water and it slows digestion. It regulates the blood sugar. Insoluble, it does not dissolve. It adds bulk to the stool and promotes the bowel motility. If you've ever tracked carbs, there's a thing called net carbs where you minus your fiber from the total carbs, and then that's how you get your net carbs. So if you have 25 carbs, you have 4 grams of fiber, then the net carbs is 21 grams, and you're like, yes, I'm winning. Yeah, doesn't really work that way. It does to an extent, but not as much as we think it does. All right, proteins, where I told you we have essential and then we have incomplete. So we have complete proteins. We have incomplete proteins. So we have 9 essential amino acids. These 9 essential amino acids are found in meat, dairy, fish, soy, eggs, poultry. If I'm a vegetarian, how am I getting my 9 essential amino acids? That's going to be hard. Okay? So incomplete is found in nuts, seeds, legumes like beans, whole grains, vegetables. So incomplete proteins can be paired with other foods. Remember, I told you they love these questions. They love them. So what can make a complementary protein? That means I eat one thing plus another thing, and I will meet my essential amino acids. Okay? So rice and beans would help you meet that goal. Peanut butter on wheat toast. If you combine the 2 of them, you get all 9 of your essential amino acids. Hummus and pita bread. Okay? So make sure you look into this. Fats. we have unsaturated, saturated, trans fat, and then we have cholesterol, which is the fats in our serum. So unsaturated, this is liquid at room temperature. It's found in olive oil, avocados, nuts. We already know, because we know olive oil and avocados and nuts, these are our healthy fats. So our unsaturated fats, these are our healthy fats. They help lower our LDL levels. LDL is the bad cholesterol, bad guy. Polyunsaturated, these are the really good fats. So they include omega-3s, omega-6 fatty acids, and they are crucial for our brain function and cell growth. We find these in seeds, fish, and plant oils. That's why your omega-3 capsules smell like fish, because they literally have fish oil in them. Saturated. This is a type of triglyceride that is solid at room temperature. This is your butter, cheese, red meat. By the way, I made homemade butter yesterday. It's very easy. And it's so good. And it saved me a ton of money. Anyways, butter's bad. It's good. It's better than margarine. But it's not great for you. Okay, so it increases your LDL, which is your bad cholesterol. Consumed in excess have been linked to increased risk of heart disease and stroke because it forms fatty plaques within your arteries, and then that can break off and cause a stroke or an MI or whatever. Recommended to consume no more than 6% of total daily intake. So if your fat intake, what was it? What was it on the other slide? 10 to 20% or something like that? Total? Oh, 25 to 35% of your total daily intake. Only 6% of that is supposed to be butter. I definitely have more than 6%. And then you have your trans fat, which is your worst fat. So this is your fried foods, chips, cakes, all of the things that we love and hold near and dear to our hearts. This increases our bad cholesterol and it decreases our HDL, which is our good cholesterol. Okay, you want your HDL to be higher. And then this is recommended to be less than 1% of your total. That's rough. That's rough. So when we talk about cholesterol, it's a waxy-like substance that's produced by the liver. LDL is the bad cholesterol, and HDL is the good cholesterol. Think H for happy. Okay. When we're talking about a nutrition assessment, we don't even realize really that we're assessing nutrition when we're looking at our patient, but we are. If the patient is sitting in front of you and they're healthy looking, they have nice hair, they have nice nails, and when I say nice, I don't mean expensive looking. I mean it looks healthy, right? The hair is not dry and brittle and breaking. The nails aren't thin and breaking off and cracked and have cracks down the middles of them or whatever. The skin is not dry. The skin is, hydrated and healthy looking with a nice color, temperature. So physical appearance can be deceiving, but it's okay to look at that person and be able to say that they have a healthy appearance. You see that a lot in physician notes, that the patient has a healthy appearance. Okay. So diet history, what do you normally eat every day? Yes. Do you look healthy, but you eat Burger King every single day for lunch? That's probably not good. Okay. Do you look healthy? Do you run marathons, but you eat chocolate every single day of your life and you just live off Twix bars? That's not good, right? So cultural preferences also come into play, especially when if you have a patient that is not eating well in the hospital, it might be because the food is outside of their cultural preference. We've talked about, hopefully you guys talk about cultural competence. That is a huge thing when we talk about NCLEX and testing. Cultural complex is very important. Competence is very important. The US is truly a melting pot. We have so many different diverse cultures. And it's important, if your patient is not meeting their nutritional needs, figure out if it is a preference situation. Okay. Physical assessment, arthrometric tools. I believe that's BMI, which BMI sucks. Sucks. Hate BMI. So, diet history. What does the patient usually eat? The time that the patient usually eats. Your patient doesn't usually eat until 10:30. They get their breakfast at 7, and they're like, "Why aren't you eating your breakfast?" Dude, I don't even eat till 10:30. Like, and then you're putting on my chart that I'm malnourished and I'm not eating, or I'm refusing to eat, right? The patient refuses to eat. No, by the time I eat, my breakfast is cold. Okay. How they prepare the food preferences on taste, salt, pepper, all the things. Physical history, hair, skin, poor wound healing, that has a lot to do with proteins. Lack of subcutaneous fat, irregular cardiovascular measurement like the heart rate, rhythm, blood pressure. This is because of all of our electrolytes, vitamins, and minerals. Enlarged spleen, generalized weakness. Can an obese person be malnourished?
Yes.
Yes, 100% yes. Do you guys remember the Grey's Anatomy episode where this lady, they kept talking about that she had just lost like 60 pounds, or maybe it was 100 pounds. I don't remember, but it was between like 60 and 100 pounds. And she's so happy about it. She keeps talking about it. Her husband keeps talking about how she just lost all this weight. And then I think she had a heart attack. I think she had a heart attack and died. And they're like, but she just lost all this weight. And it's because no matter what size you are, if you're in a calorie deficit and you're not eating your essential nutrients, then you will be malnourished, which then affects your muscle mass. It affects your vitamins and minerals. It affects every part of your body. And they actually, I think in the episode, they ended up relating it to muscle atrophy and relating it back to her heart health and malnourishment. So remember that. An obese person can 100% be malnourished. You don't have to be stick thin to be considered malnourished. This is your BMI chart. It's absolute trash. This doesn't take into consideration your muscle mass at all. So a man that plays in the NFL that's 350 pounds and 6'8" has a BMI that's like 50. But it doesn't make any sense because dude isn't fat. He's 6'8" and he has huge muscle mass, right? So a lot of providers are going away from BMI charts, not as fast as we would want them to. But the reason is because there's not a great way throughout the medical community where they test your muscle mass. So, you know, they have that machine sometimes at the gym where you stand there with bare feet and you have to hold on to the things and you have to stand there for X amount of time. And it measures your bones and your water and your muscle and this and that. Why is it available in a gym, but it's not available in your doctor's office? Great question. I have no idea. But that would be a better measurement on health because America. Exactly. Exactly. That would be a much better measurement than this chart. but we still go by this chart, which is dumb. Okay. So this is important. Labs. So for fluids, your eyes and nose, you want to take in 2 to 3 liters per day. You want to put out anywhere from 1750 to 3000 mLs per day. Protein levels. This is in your blood. So your total protein is between 3.5 and 5. By the way, I uploaded into Brightspace the ATI lab reference for all of ATI, not just critical care and nutrition. This is all of ATI. Every single lab reference that ATI uses, which is what NCLEX uses, is on your Brightspace. You should print it out. You should keep it forever or download it or something, because I'm giving it to you. If you don't, I don't know if you'll ever get it back. Okay, I don't know if it's like available to you guys on ATI. Prealbumin, this is low for critically ill patients and can show malnutrition. Albumin is a type of protein. Nitrogen balance is the relationship of protein breakdown. When you have a large amount of protein breakdown, you have more nitrogenous waste, and it affects the kidneys. Are you supposed to have protein in your urine? Huh? No. No. No, no, no. Okay, think about the kidneys. Think about the structure of the kidney. You have your nephrons, and inside the nephron, you have your glomerulus, your glomerular filtration, all up in there. Okay? Protein molecules are large molecules. They're not meant to be filtered through those little teeny tiny glomeruli. Okay? So there, and they make it through, they can cause injury to the nephrons, resulting in an AKI, an acute kidney injury. Okay? When you're dumping protein in your urine, that is bad. Bad, bad, bad. Risk factors for inadequate nutrition. We have medical diseases, conditions like hypertension. I'm sorry. This is saying nutrition can have a large effect on people that have these disorders. So if you're hypertensive, you can't be eating a ton of salt, right? Because salt attracts water. The more fluid you have in your body, the higher your blood pressure is. That's the idea. Okay. HIV, AIDS. If you're malnourished, you're not meeting your goals, your essential macro and micronutrients, it's going to affect your immune system. Okay. Preventative measures. Surgeons are really big about protein intake because it's essential for wound healing. So people that, or have a chronic illness, sometimes are told to follow a very specific diet, higher in protein, to make sure that they have enough, or other nutrients to make sure that they have enough to prevent bad things from happening. Geriatric predisposition. There are natural things that happen because of age. June, you can't send out your book code. That book code is only for you, girlfriend. Everybody gets their own book code. I just didn't want other people to take it. Sorry. Because if they try to use it, if they use it before you use it, then you're screwed. And then you need a new one. But then once you use it, it won't work for somebody else. So, geriatric disposition, this is people that have osteoporosis or are immobile or some other type of geriatric normal issue or not normal issue, just happens with age, is a huge risk factor for malnutrition. Age, mental illness, excess stress, negative self-concept. This includes anorexia, bulimia. This also includes binging, binge eating disorder. They like to forget that. Little tidbit up there. I have that. My brain hates me. I love food. You're welcome. Use of comfort food. So when we talk about eating disorders, eating disorders can affect everyone over a very large spectrum. There's a large spectrum of eating disorders. And can a fat person or obese person have an eating disorder? Yes. Yes. 100%. Okay. Binging and purging, right? You binge all your food, then you get sad about it, and then you throw it up. That's called purging, right? You binge and binge and binge and binge because your brain tells you that you have to have it, you have to have it, you can't. That's a binge eating disorder, okay? Your brain won't let you eat. You convinced yourself that you can't eat because if you gain 1 ounce and you haven't lost weight this week, that it's going to be the end of the world. It is an actual mental health disorder, all of them, okay? And they should be treated as such with the adequate help. We've all seen this. This is the My Plate thing where they tell you to try to like measure your foods. So dietary guidelines are developed by the Department of Agriculture and Department of Human and Health Services. Healthy food selections, including fiber-rich fruits and vegetables, low-fat milk, lean meats, poultry, fish, legumes, eggs, nuts. We want to increase physical activity and follow our healthy eating guidelines. I'm pretty sure they changed yep, they did. They changed the eating pyramid. So at the bottom, they included daily exercise and weight control. Then comes vegetables and fruits, healthy fats and oils with whole grains. Then comes your other healthy fats. Then comes the rest that you want to use sparingly. Red meat and butter, refined grains, white bread, rice and pasta, sugary drinks and sweets and salt. They hate me. That's what they're saying. They say they're looking at me and saying, I hate you. You suck. At least I did eat chicken yesterday, so. Promotion of healthy body system, cardiac. You want to limit saturated fats to less than 7%. You want to limit the intake of red meat, refined grains, added sugars, butter, high sodium, commercial trans fats. Neurological, we need our B vitamins and magnesium. Bones, we need calcium, magnesium, and phosphorus. Bowel function, we need adequate fluid intake. And I feel like the fiber should be under that one too. And then cancer prevention, high fiber. We're talking about colon cancer because the fiber helps keep things moving. Cultural, ethical, and religious. They love to test on cultural preferences. So please make sure you're looking in your ATI nutrition book about cultural preferences. Also religion. I don't know if it's the first or the second largest religion is Muslim. So Muslim faith, you can't have any pork products. Gelatin is made by pork products. Did you know that capsules for pills are made with gelatin that is made from pork products? So if your patient is refusing their medication and they're Muslim, it could be because the capsule is a pork byproduct and they need their pill in a different manufactured capsule. They do make capsules now that are not pork byproducts. Okay. Okay. Types of diets. If you didn't know by now, I hope you do, that NPO means nothing by mouth. It's NPO because it's Latin. Should be like NBM, which I guess doesn't roll off the tongue like NPO. Clear liquids is anything that is transparent that you can see through and is liquid at room temperature. This includes Jell-O. This includes Jell-O. Because apparently if you leave Jell-O at room temperature long enough, it will like liquefy. I didn't know that. I thought it just stayed a gelatin. But Jell-O is included in a clear liquid diet. Full liquids are any kind of liquid. So things like orange juice, milk, coffee with creamer, ice cream, soup that doesn't have anything in it. I remember after I had my gastric sleeve, the very first time, I was on a liquid diet for so long, and the very first time that I had cream of mushroom, strained, by the way, you had to strain out the mushrooms. I don't even like mushrooms. It was the most beautiful thing I ever put in my mouth because I was literally living off chocolate Fairlife protein. And it was just so amazing. Soft diet, this is comprised of soft foods that are low fiber, so they're easy to digest. Low fat dairy, eggs, pudding, bland vegetables, tofu, lean, skinless meat. Dysphagia diet, this is soft foods that are moistened or pureed, as well as thickened liquids. So dysphagia, if you have difficulty swallowing. Regular diet is exactly what you think it is. It's a regular diet. This can be different at different facilities. Okay, so it's very, I would go by your ATI book, but in real life, real world, every facility is going to be different. It's going to be mostly the same, but just little tiny inconsistencies. So cardiac diet is going to be low in fat and salt. You can have low fat meats. Fried foods and caffeine are not allowed. It's very sad. The diabetic diet is a low fat diet that will vary in calorie level based on your age, size, and activity level. It limits carbohydrates. There's also different levels to the carb diet. So if you're like a really bad non-compliant diabetic, you can have like a lower ratio of carb diet in the hospital, where they 20 grams of carbs per meal. And the lowest one is like 40 grams of carbs per meal. Like it depends on your, I think it depends on like your A1C. So the high fiber diet, this is a high fiber diet that can be helpful with certain health problems. It helps to relieve constipation, helps reduce hemorrhoids, recommended for people who have diverticulosis or irritable colon. And then lactose free is exactly that. It is milk and dairy products that do not have lactose. Low fat is exactly what you think it is. It's less than 50 grams per day of like total fat. Low protein. When is low protein essential? What did I tell you protein does to the kidneys? It hurts them. I forgot how quiet you guys are. I really did. I really forgot. It kills me. It kills my soul. You are the only class that doesn't talk to me. Gotta talk more to me. I need people to talk to me. So if your patient has renal insufficiency, chronic kidney disease, renal failure, they're going to have low protein in their diet. Okay, see where it says renal diet? It has low protein. Also, low potassium, salt, phosphorus, but also low protein. Low sodium. This limits the salt to 2 grams or 2,000 milligrams of salt per day. And no concentrated sweets. That's just sad. This diet is a regular diet that does not have sources of simple sugar. So no sugar, honey, syrup, jam, jelly, molasses. It's just sad. I've never seen that diet in a hospital, never in a million years. Okay. Enteral nutrition. After this, we're going to lunch. Enteral, meaning intestines. Enter, E-N-T-E-R. That is a medical term for intestines. Okay? So when you see enteral, that means it's going through the digestive system. It's going in your mouth, down your esophagus, into your stomach, into your intestines, and maybe out of your butt. It might come out of a different hole if you have a colostomy. Okay? So the routes, this can be, nutrition provided by the GI tract. What do you mean without patient eating and swallowing? First of all, enteral nutrition includes food that is going into your digestive system, okay? Whether that is through a G tube, a J tube, a GJ tube, a button, a PEG tube, an NG tube, an OG tube, or whether you are eating it. That is all enteral feeding, okay? So when you have any of these other routes is when you have a patient that's at risk for aspiration or is already aspirating. They have dysphagia. They're unable to swallow or have difficulty swallowing, which causes aspiration. This can be caused by a stroke. They're mechanically ventilated. They have an obstruction in the esophagus. Severe burns, because if you have severe burns, you're most likely on a ventilator. Or especially if you have severe burns to the face, throat, abdomen, you may need different types of nutrition. So an NG tube or an OG tube, this is a tube that passes through one of the nostrils, or we like to call them nares, down the throat into the stomach. What do you need to do before you put in an NG tube? Patency. Make sure that the nair is patent. Make sure you don't have a septal deviation. Look in the nose. What else do you need to do? Am I just shoving?
You gotta measure it.
I gotta measure it. Where am I measuring from?
Tip of your nose, the tip of your ear, and then to the...
What is that called? The xiphoid process. Yes. Okay. A PEG tube. This is a percutaneous endoscopic gastrostomy. This tube is inserted through the abdomen directly into the stomach. A J tube is a jejunostomy. This tube is inserted through the abdomen directly into the small intestine, so the jejunum. A NJ tube is a tube inserted through one of the nostrils, down the throat, and into the jejunum. They also have GJ tubes, which is gastro and jejunal. So there's 2 ports. One goes into the stomach, one goes into the jejunum. Okay. Nursing care for people that have tube feeds. You want to check the tube feeding residual every 4 hours. What happens with you withdraw 60 mLs of residual tube feed? What do you do with it? You put it back. Why?
It's still nutrients.
Because of their stomach acid. Because if you take away all of your stomach contents, all of the acidity in their stomach, it is going to put them at risk for alkalosis. Okay? You can't take away all of the acid in the stomach. It will cause a pH imbalance. And we're going to get into that later when we talk about acid-base balance. So return any residual back to the stomach. Do not discard unless specifically ordered by the physician, because it could cause fluid and electrolyte imbalance. If the residual is greater than 400, you stop the feed and you tell the provider. Okay, you do not keep going. You stop the feed. Flush the tube with 20 to 60 milliliters of water to prevent clogging. Monitor skin around the site for any signs of breakdown, around the nose, the bridge of the nose, because sometimes it's taped to the bridge of the nose. Around the peg tube site, you want to make sure that there's a split gauze under there. Make sure you're changing it and looking under there, because there's a lot of moisture, can cause redness, irritation, itching, skin breakdown. To prevent aspiration, we need to keep the head of the bed at least 30 to 45 degrees. External, monitor the external length of the NG and OG tube. So when you put it in, can you just start tube feedings? No. What do you have to do? Check placement. How do you check placement? A chest x-ray. Yes. Can you check placement by air aspiration? No. Do we do it? Yes. Yes, we do. Is it proper? No. No, it is not. No. Not when you first put it in. Okay? When you first place the tube, it has to be confirmed on an x-ray that it is in the right place, that it's at the right length. Okay? Can you test that you're in the stomach after you've confirmed placement? Can you test that it's in the stomach with air aspiration? Yes. How else can you test? pH. Yes. I have yet to work at a facility that has pH strips available to me to test my gastric contents. Never seen it. I'm sure somewhere they have them, but it is an answer if the answer is available. Okay. You want to monitor bowel sounds. If a patient is on tube feed, what's going to happen to their poo? It's going to look the same way coming out that it did going in. Okay. Eventually. Eventually people will tolerate tube feeds better. When we talk about tolerating tube feeds, we're also talking about it coming back out. Okay. You don't want your patient sitting in liquid stool. I don't care if you check and change every 2 hours. If they're constantly in liquid stool, their skin is going to break down. Okay. You have different formulas. I am not going to test you. Oh, I'm not hardly This is important because it has nursing aspects, especially for critical care. Because every single one of your patients that is on mechanical ventilation has an OG tube. Every single one of them. Every single one of them. Are you using it for tube feeds? I don't know. That's not up to me. Are you using it for PO meds? Yeah. Are you using it for other things? Yes, absolutely. Every single patient that is mechanically ventilated will have an OG tube. Okay. So is this testable material? Material. Yes, it is. Parenteral. So I told you enteral means intestines. Para or pair means around. Parenteral, around the intestines. So this is your PPN or your TPN. This is nutrition that does not go through any part of the GI system. So this is nutrition that's provided intravenously. It is used for patients that have prolonged. I want you to put a big fat star and underline the word prolonged. NPO. I came in and I'm NPO for a procedure. Are you going to put me on TPN? No.
No.
No. I came in, I'm admitted for a Crohn's exacerbation. I've been NPO for over a week. Am I a candidate for TPN? Yes. I am having a Crohn's exacerbation. I have been NPO for a freaking week, and who knows how much longer I'm going to be NPO because of this exacerbation. There's no end in sight. I need nutrition. Small bowel obstruction, paralytic ileus. What is a paralytic ileus?
The intestines stop moving things along.
The intestines are paralyzed. This happens commonly after surgery. It takes a little bit for the bowels to wake back up and start moving again. Enteritis is inflammation of the intestines. There is a higher risk of sepsis than enteral feeding. Why? Because it's going through an IV. Because it's what?
It's foreign contents in your body.
It's more about the delivery, because with TPN, you have to have a central line. That's very important. See these red words? The red words are important. Okay? So TPN, you must have a central line. When you have a central line, you automatically have an increased risk of infection. What is included in TPN? Sugar. What loves sugar? Bacteria. Okay? So what are things that you have to watch for or do in your nursing care when we talk about parenteral nutrition? You have to monitor the site. If it's PPN, which can only be for a very short period of time until you get a central line, I've never even given PPN, ever. I have never given parenteral nutrition without a central line. And I wouldn't want to, because it is really, really hard on the veins. Okay. And it only provides partial nutrition. So it's really just crap. Like the patient needs a PICC line, they need an IJ or an IJ, they need a femoral line, they need some type of central line, a port, something. So PPN, the very important thing you need to know about this is that it's partial, it's not complete nutrition. It can only be used for short-term use only, and the patient is hugely at risk for thrombophlebitis. You can tell I need a break. My lips are... Okay? TPN, this provides all of the nutrition. It must be infused through a central line, and it can be for long-term use, for as long as you have the central line and need the TPN. Okay? So you want to monitor the site for infiltration or leakage. Change the bag and IV tubing every 24 hours. This is mandatory because of the sugar content. This is one of the ways that we decrease the risk for infection. TPN that contains lipids require a micron filter. That is also extremely important. It comes up from pharmacy with the bag. And then we want to monitor electrolytes, glucose, I's and O's, and daily weights. Because all of their nutrition is literally mixed in this bag. So they have to have daily labs for the pharmacy and dietitian to correctly formulate their TPN. TPN is specific to each individual. You don't just like get it out of a box and hang it. This is specifically tailored to each and every single patient. Okay? You cannot, this is a huge one. You absolutely cannot administer any other fluid or medications in the same line as a TPN. You'll notice that the line that they give you to hook up your TPN, it has no ports because you cannot use them. It is unacceptable to put any other medication or fluid in with your TPN. You also don't want to draw blood from your TPN line because you can get blood from a central line, right? If you do, your electrolytes and your glucose are going to be crazy. So these last two slides are very, very in hospital times, it's necessary healing, recovery, reduction of morbidity, consequently reduction in length of stay. And that is the end of that one. Thank God. So, questions about nutrition before we go eat our lunches that are probably not nutritious. So what do I care about? I care about things that affect my heart, my kidneys, my acid-base balance. I care about enteral and parenteral nutrition. I care about you knowing the difference between water and fat-soluble vitamins. I care about that a lot. I care about electrolytes a lot. Okay. Questions?
What was the first thing you said before kidneys?
I don't know. Oh, heart.
Okay, thanks.
Are we using the gerontological? I guess we're just confused what goes where. I thought it was the MedSurg book and then just the VSIM book because we have SIM for assignments, then VSIM for clinical. The two code, I don't know what gerontological, there is no gerontological book. The other code
We
is
got
for
a code for it. I don't know why. So Sandra sent us the codes, not Terry Chapman, and we got a code for the VSIM for nursing one, and then we got the one for the gerontologic nursing. So we were all just confused what
No,
goes where.
there's no, I'll tell Terry, there's no gerontologic nursing.
Well, I put
Okay.
both the codes under the both course codes under the book that she sent the first one, which is the VSIM. And so now I'm confused if I can add it to the MedSurg one or as well.
It should still show up under your MedSurg book. I don't know.
Okay, I'm gonna go check.
I just wasn't sure about the.
I only got one code.
Because you already have access to your Honan books, your big MedSurg books. So one of the codes that I sent you in the email that's in Brightspace for Lippincott should automatically work because you already have the MedSurg book, right? It's the
Yeah, so
other.
I was able to get them both under there, and then they're both under the VSIM one. I just wasn't sure if we needed that gerontological one too.
No, no,
Okay.
that gerontological book is not for you. Nope.
I did not receive the gerontological one.
Good. I'm glad.
That's the old curriculum.
Did anybody else receive the gerontological book code?
I think a few of us at Sylvania did.
I did.
Is that all?
I think
Is
it's
that
a Sylvania
just
thing.
Sylvania?
Niles. No, I'm from Niles. I got one.
Okay.
And when
They
I
took
clicked on it, there's
They took
no assignment.
out of our program completely. I don't know why. You
Say
guys
that
are
I
getting-
didn't receive it because I already have it. I was in the old curriculum.
Okay, as long as you can get into both Lippincott courses, that's what matters. So if you go put in your codes for Lippincott and you get access to both courses that says Simmons, that's what matters. If you cannot do that, then we need to talk.
I just tried to put in the second code and it popped up, but then it says this course requires additional content you do not own.
Okay, so you need a course or a book code for that course. Whoever that was.
That'll
Okay.
be the VSIM book code that you got sent in your email. The gerontological book is like irrelevant. We don't have to touch that thing at all.
No, I don't know anything about a gerontological book.
So in both my course codes, they just have VSIMs. It doesn't have any actual assignment.
Yeah,
in my MedSurg or the new book code that
Yeah, I think it's
Sandra
because we
said.
don't have like prep use or anything this month, so it should just be the VSIMs that are there.
Assignments. The only assignments you have
Okay.
are the two VSIMs. And the reason that it lasts all month or 2 months is because it's for complex care 1 and 2. The only assignments that you have are for ATI, other than the two Lippincott VSIMs.
So each one, just to verify, complex care and then Simmons complex care, each one we have to go into for the whole month, or is one for this month and one for the next month?
No, they are both active for 2 months.
Okay.
Okay. All right, let's go to lunch. I'll see you at 12:30. Okay. Hello.
I was like, I don't know if she meant it as like one word. So that's what she
You're fine. It tastes perfect.
so maybe the when does Bright Space close in the last week?
Saturday.
So we need to have our clinical packet for that Thursday or Friday.
Oh, 100%. Yeah. And on that Friday, I'm going to be literally like making sure I have all my stuff, checking off. So if you're missing anything, like probably that Thursday, that Friday, you're going to get an email from me saying, hey, what's up?
That works, just so I have a game plan in mind for how I'm gonna do homework, clinical packet. Plus that. I think Tuesdays are gonna be my homework days.
So I will say, I knew it was going to be so like stupid expensive. Because the matcha, well, both of it. I will say that I feel like my students, and I feel like at least that complex care 1 is easier than complex care 2.
Great.
Because complex care 2 is like super heavy on cardiac. And you know, cardiac is just my bread and butter. I just love it so much. So I'm like super excited. And everybody's looking at me like I'm crazy. And I'm just like, this is the best day of my life. You guys are going to be so much fun during that.
Wait.
How was your nutritional lunch? Not nutritional.
I ate junior bacon cheeseburger fries. I got a wrap.
You know, I haven't had a good junior bacon in a long time. When I used to, before my bariatric surgery, when I used to binge really bad, food that I ate in the car didn't count because I was by myself and nobody could see. So your girl would go through Wendy's and get like 2 junior bacon cheeseburgers and smash them in the car and then go home and eat dinner. But it was my little secret because nobody knew. And I wondered why I was, you know, couldn't lose weight.
Miss Simmons, I have a question about the exam.
Oof, I'm not giving you answers, Amanda.
No, I won't ask about that. I was wondering if they're case studies. Is that all that they...
Case studies on the exam?
Yeah, I think I heard that it was just case studies.
Who told you that?
One of our teachers just told us that
she said it was like
that damn Miss Belay. She just told us.
You're talking about the NCLEX. The NCLEX has an insane amount of case studies.
No, she literally told us that in complex care, our tests were only case studies. So that's why she wasn't going to give us that many.
First of all, how would she know that?
Yeah, she gave us a case study and didn't realize that she like did.
Who informed her of this? I would love to know.
And it was 23 points.
Yeah, she gave us a case study on our first exam that was 23 points.
I will say that I do have a case study. I don't remember if it's for complex care 1 or 2 because I haven't looked at my exams in 2 months. But it's not the whole exam. I mean, it's only one part of the exam, and I would never in a million years, take up 23 points on a case study. Never, ever, ever in a million years. Because that's only covering one concept.
Yeah, that was our second exam, and we all were in the parking lot freaking out because we all got 60s.
It was bizarre.
On our exam, and then she gave 22 points back.
Huh.
Yeah, it was something.
It sounds like something. Sounds like something super interesting.
Like it was like 62, 64% that we got on exam two. But we got like 90s, 95s on exam one.
Wow. I don't have a ton of words for that, but the answer is no. That is not how we are doing tests in complex care. I don't know who told her that. Do I utilize case studies? Yes, I do. I do like them. I think they have a purpose. I love using them in class specifically so that we can talk about the concepts and put them in like a real world scenario. I did make a case study one time that was 16 points. But the way that the case study is built in ATI is that you have the same information throughout each question. And if you don't just like fail the case study, like every part of the case study is worth its own points. So if question 1 is a multiple choice, it's worth 1 point. If question 2 is a select all that apply that has 3 answers, it's worth 3 points. You know what I mean? So if you miss the first question, but you get the second question right, you just got 3 out of 4. You know what I mean? Like it's just like any other test question, except 5 or 6 of the questions go together in the same scenario.
See, I don't know, because she didn't explain to us why we got so much points back, but she said we did well on the case study, so I don't know if ATI automatically, if we clicked one wrong answer, marked it off.
No, because there's only one way to build a case study in ATI. So, I don't know. That sounds crazy to me. Okay, are we ready? Oh, by the way, the geriatric codes are wrong. There was a list, there was like 5 of you that was on the wrong list. Marissa, you were one of them. I don't remember all the other ones. It was only like 5 people that got those gerontology book codes. Did you already try to use them?
I did. I already have been accepted into the course or whatever.
Yeah, that's not your course. That
Okay.
is, you don't want nothing to do. First of all, that's an LPN course and it's 1775. You do not need to take an LPN course for gerontology. So please, if you can leave the course, that would be great. I'm pretty sure that they are they're going to like take the book codes back because like I said, there was only like 5 of you. So you already have access to your Hunin, I don't know how you say it, Med-Surg Big Black Book, right? Does anybody not have access to that book? You should all have access. Okay. Unless it's been over a year since you took Med-Surg. I mean, that happens for people. That should really be the only reason that you don't have an active book code for that book. You should only be receiving 1 book code, and it is for the VSIM book. Okay. All right. Oh. I like. All right, let's get into it. So, fluid, electrolytes. Did I share my screen? No. All right, fluid, electrolyte imbalances, and acid-base balance. A beautiful concept. Labs to evaluate fluid status. Now, I provided you with the ATI lab reference papers for a reason. Okay? Let me pull that up. So on here for let me see. I don't think it even has a hematocrit on here. I'm not going to ask you about hematocrit, by the way. Reference? Yeah, it's included now. So, albumin, we were talking about albumin on the nutrition one. Like it says 3.5 to 5. BUN, this is the same, it says 10 to 20. Creatinine is super important. The usual, like normal creatinine range is 0.6 to 1.2. Now in the lab reference range, the ATI one that I put on Brightspace, it has different numbers for different age groups. So 41 years to 61 years, it goes up to 1.3. And then 60 years and older, it says 1.3. So I would never put 1.3 on an exam and have you tell me if that was normal, high, low, whatever, right? I was always taught that a normal creatinine was 0.6 to 1.2. Every facility is going to be different. And this is why I gave you this reference range. So please use it. Okay? Like this says a normal sodium is 136 to 145. I've never heard that before in my life. It's always been 135 to 145, but according to ATI, it's 136 to 145. Never have seen that in my entire existence. I'm looking for urine. That's what I'm looking for. Here we go. Urine specific gravity. Please write this down. On ATI, your urine specific gravity is 1.005 to 1.03. 1.005 to 1.03. That is a urine specific gravity according to ATI. Okay. So osmolality, this is the concentration of fluid that affects the movement of water between fluid compartments by osmosis. We've talked about a long time ago, and hopefully you remember, water follows salt, right? So if you have 2 cups and you were doing a science experiment, and one cup had really high concentration of salt water and the other cup was just regular old water, and you put a paper towel or a lot of like kids science experiments do like a paper towel, you will have the water leaching from the cup with less sodium into the cup with more sodium until the sodium equals, or until it takes all of the water into the sodium dense cup, because water will always follow salt unless we have a drug that interrupts it, like a diuretic. Okay. Some diuretics even do work by the water following the salt though. Okay. So, urine specific gravity, I do want you to know that number that I gave you. I want you to know a normal BUN, and I need you to know a normal creatinine. Homeostasis, this is the state of steady internal physical, chemical, social conditions maintained by living systems. We are achieving homeostasis every single second of every single moment of every single day, okay? The organs that are involved in homeostasis include the kidneys, the lungs, heart, adrenal glands, parathyroid glands, and the pituitary. So the kidneys regulate the blood pressure. They start off the RAS system, the renin-angiotensin-aldosterone system. Remember that? Way back when? The adrenal glands sit on top of the kidneys. And they put out hormones. The parathyroid and the pituitary gland release hormones. The lungs are not only involved with your acid-base balance, breathing, obviously, they also have a part in the RAS system, converting angiotensin 1 to angiotensin 2. And then obviously the heart is the heart. IV therapy, ICF, that when we talk about ICF, that is intracellular fluid, the fluid that lives inside of the cell. This is where most of our fluid is inside of the cell. ECF is your extracellular fluid. This is the outside of the cell, okay? There's two types. There's interstitial fluid, which is the fluid that surrounds the cells. This is basically part of your serum, okay? And then your intravascular fluid, plasma fluid in the blood vessels. Solvent. This is the liquid component that is dissolving what you're putting in it. So this is the water. The solute is the salt. Or whatever, any electrolytes. Okay, salt is just the easiest one to use. Okay, if we were making sugar water to make iced tea, the water is our solvent, the sugar is our solute, because our solute is dissolving into the solvent. Does that make sense? So, really quickly, when we talk about electrolytes, and we talk about big numbers versus small numbers, like we just said, a normal sodium, this is going to take a long time for me to say this in the right way, because my brain just says 135 to 145 automatically. And I really want to know why ATI changed it. But anyways, so sodium, the normal range of sodium is so much higher than potassium. Why? Do you think it's intracellular or extracellular? Where is most of your sodium? Is it in the cell or out of the cell?
Outside.
Outside of the cell. When you draw blood and you get your electrolyte levels from your CMP or your BMP, it's from the serum. It's not from the cell itself. It's what's floating around outside of the cells. Okay? Potassium is an intracellular ion. That means that most of potassium lives inside of the cell, and only some of it lives outside. Okay? So when something causes hyperkalemia or hypokalemia, we're going to learn something very, very important next week. And that's that in order to, the fastest way to treat hyperkalemia, which we have to treat it quickly because it can cause arrhythmias, dysrhythmias, and cardiac arrest, right? Hyperkalemia and hypokalemia, both. So the fastest way to treat hyperkalemia is with insulin, IV regular insulin. Why? Because when insulin enters the cell, so does potassium. Okay? So when you have an intracellular ion that is too high outside of the cell, that's when it causes problems. And we have to fix it fast. Same thing with sodium. If there's not enough sodium within the serum, then we need to replace it and give more. If there's too much sodium outside of the cell in the serum, we need to remove it so that our patient doesn't have seizures and go into a coma. Okay? That makes sense. I feel like that was a little confusing. She said no. At least she's
It
on
makes
it.
sense.
She said nope. She shook her head. She said, mm-mm. It makes sense to somebody on here. How do serum and plasma differ? I've been using them interchangeably when you have a moment. So we have two different fluid systems. Excuse me. You have your intravascular system, which is your blood, and then you have your interstitial fluid, which is your I want to say like immune circulation. So you know how we have lymph nodes, and between those lymph nodes, there's lymphatic vessels. Okay. And our interstitial fluid lives in those lymphatic vessels, and they go from stop to stop, which is your lymph nodes, and they pick up B cells and T cells and blah, 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 and they have their own circulation, right? Then we have our blood circulation, which is your cardiovascular circulation. So they are two separate things. Your blood plasma and serum are basically the same thing. Okay. When you talk about plasma specifically, it's usually when you're talking about donating plasma. And what that means is they take blood out of your body, they spin it down, and where all of the contents in your blood hit the bottom, and all that you have left is that clear fluid, that's plasma. They take the plasma and then they put the rest of the blood back. And that's what you donate. You donate just the plasma. So that's the clear stuff that separates from your blood. When I talk about serum, your blood serum, that just means I'm talking about the extracellular components of your blood is your blood serum. It's outside of the cell. It's the extracellular fluid. That's where your extracellular glucose is that we test for, right? When we run labs, we're testing the extracellular fluid. You look you look confused. Talk to me. What doesn't make sense? It's okay. Everybody. I need you to understand the words that I'm saying. So I want to make it easier in some way because I feel like it makes more sense now. Okay. So I need you to understand that there's a huge difference between intracellular and extracellular, okay? Sodium and potassium live on a teeter-totter because the most of the potassium lives inside of the cell because most of the sodium lives outside. So if you have too much sodium out here, it's going to cause a influx of sodium or potassium to go in, causing hypokalemia in the serum. So it's a teeter-totter. Too much sodium out here is going to be not enough potassium out here, which means if there's an imbalance outside of the cell, then there's an imbalance inside of the cell. Okay?
So if there's too much sodium, then there's not enough potassium and vice versa?
Yes, because they teeter-totter. So if one is high, the other is low, and vice versa. Okay, because of our sodium-potassium pump. Diffusion versus osmosis. Diffusion is the movement of both water and solvent. It moves from a higher concentration to a lower concentration and dilutes the fluids. Osmosis is the movement of water through a semi-permeable membrane. What is a semi-permeable membrane? It's like a colander.
Things can pass through it.
Yes. It's like a colander. So you have colanders that have really big holes. You have colanders that have little tiny holes. You have little sifters that have like really, 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 really tiny holes, right? So semi-permeable means that it only allows some things to go through, okay? And osmosis is truly just the movement of water. Okay. So diffusion is both the water and the solvent. And osmosis is the movement of water. IV solutions. We have 3 different types of IV solutions. We have hypotonic, which is an IV solution that has lower concentration of dissolved particles than blood. So this is our 0.5% saline, our 1/4% saline. This is used for cellular dehydration. That means the intracellular is dry. This helps the kidneys excrete waste, fluid volume loss from dehydration, and vomiting. Isotonic, this is your safest place. This is what 90% of your patients are going to be receiving throughout your career. The solute and solvent are equal parts and are most comparable to your body's natural ratio. So this is used for safe fluid replacement, blood loss, dehydration, fluid maintenance, and examples include normal saline and LR, lactated bringers. I want you to hear the words that come out of my mouth. Isotonic fluids do not cause a fluid shift. They do not cause a fluid shift. What does that mean? When I give a hypotonic or hypertonic solution, it is going to cause a shift in electrolytes. That's the purpose. That's what it does. Scientifically, that's the job. Isotonic fluids, because it is as close to our body's normal ratios, will not cause a shift in electrolytes. Okay? That is the most important scientific difference that I want you to know. Hypertonic fluids are IV solutions that have a higher concentration of dissolved particles than blood. This can be used for fluid volume overload. The most I've seen these fluids used is for severe hyponatremia. And that's with 3% saline and 5% saline, which I've never seen. I've only seen 3%. These are extremely critical fluids. We are not handing these out all willy-nilly. No, ma'am. Never, never, never. Okay. 3% saline can only be given at 25 milliliters per hour for 4 hours. That's it. And it can only be given through a central line. Well, what if the doctor orders more? Well, you bet your bottom dollar you're getting a BMP before you do that.
Miss Simmons?
Yeah.
You said hypertonic hydration.
Hypotonic?
No, hyper.
Hypertonic is not used for, no. Hypertonic solutions can be used for hyponatremia. Fluid overload. And when we're talking about D10, that can be used for hypoglycemia.
Okay, thank you.
So again, 3% saline can only be given at 25 milliliters per hour for a maximum of 4 hours before you have to reevaluate the sodium levels. Okay. I need you to know the difference between fluids. We all know what a peripheral line looks like. This is a normal, thin, flexible catheter into a peripheral vein. It comes in different sizes. Always, always, always flush your line before you give meds. Always. I don't care if you're in a rush. I don't care what you're doing. You always want to ensure patency of a peripheral line before you give anything through it. Okay? A midline is a type of peripheral line that extends into the axilla. So a midline usually starts in the forearm and goes up into the axillary, which is where your subclavian vein is. So it goes up into bigger vessels, but it's not a central line. It is a midline that it can last longer than a peripheral, but it can't last as long as a PICC line. Okay. So a PICC line is a peripherally inserted central catheter, which means it's peripherally inserted. It's in one of your arms, usually in the upper arm, goes in through the subclavian vein and into the right atrium. A central line must go into the central place of the body. Okay. So, central lines can end up in both the superior vena cava and the right atria. Some medications require central lines to prevent complications. That includes TPN. That includes all your pressors, vasopressors. You can give sedation medications through a peripheral line, but if your patient is in the ICU, they have pressors going, you might as well use their central line. There's really no point in using a peripheral line if you have a central line. Okay. Nursing management, you want to make sure that you are changing the dressing under sterile procedure. That means I have a mask, you have a mask, the patient has a mask, We're using sterile gloves. It comes in a sterile package. Or if it's saturated and needs to be changed. CHG, that stands for chlorhexidine. This cuts down on what we call CLABSIs. CLABSIs are catheter-associated blood infections. CLABSI, bloodstream infections. Centrally associated bloodstream infections, CLABSI. Okay? Every hospital system throughout the country, I don't know the world, I can't speak for the world, but the country specifically, we are all fighting against CLABSIs and CODIs. CODIs, what are CODIs?
Catheter-associated
UTIs.
urinary tract infections.
Yes, perfect. So there's always going to be your nurse manager or your charge nurse or somebody that's on your ass about pulling your Foley and getting your central line out. Is it necessary? Do they need it? Do they need it? Do they need it? Even though it makes your life so much easier to have it, we need to pull it as soon as it's not necessary anymore so that our patient is at less of a risk of infection. So again, we talked about the PICC line. It's a peripherally inserted central catheter. It's inserted through a peripheral vein, threaded into the superior vena cava. The tip can and sometimes will absolutely be in that right atria, which is why sometimes it can cause dysrhythmias when they're being put in, which can be very scary. Okay. This is only for long-term medication therapy or TPN, because we're not just doing this to anybody. We're only doing it when we absolutely have to because of such a high risk of infection. There's a high risk for clots and obviously infection. And it's inserted by a special nurse called a PICC nurse, and she has a ultrasound. They also have this thing, it's called a bullseye. So if they get this bullseye when they put the PICC line in, they don't need to have a chest x-ray to confirm placement, because that bullseye confirm placement. If they don't get the bullseye, then they have to get a chest x-ray to confirm placement. You should always get a chest x-ray anyways, because that is the only way to 100% confirm placement for a central line. Okay.
Hey Jessica, it's kind of off topic, but to become a PICC nurse, how would you go about that? Like, is that something you have to take a class for? Or do you have to have so many experience as an RN? Like,
I
become a PICC nurse?
I actually don't know. I'm sure there is a very specific I don't know. There's obviously a class. There's a huge training thing because they use very special equipment. Because even there are nurses that use ultrasound to have like ultrasound guided peripheral IVs. I mean, I can do that, but I would never in a million years be comfortable placing a PICC line. Like, that needs very specialized training. Where do you get that training? I don't know. Is it through the hospital? Is it through another source? I don't know. Good question, though. A portacath, also called a metaport, is a small implantable port placed underneath the skin and connected to a central vein. This is for long-term medication management, chemotherapy. It does have a lower risk for infection if it's taken care of properly. And what I mean by that is taken care of by the person initiating and providing the medication, fluid, whatever. Because yes, it's underneath the skin and it's protected in that way. It's protected by the skin. But if you are a nurse that doesn't scrub their hub, first of all, we have beef, and that makes me really mad. But also, your patients that are on chemotherapy are also at a huge risk for infection because their immune system sucks. So you go in, you're in a rush, you don't scrub your hub, you go to flush a port, you flush it, you don't know what's on that port. You don't know what was on that. You never even cleaned it. So whatever was on the surface of that is now injected straight into your patient's central line. And you also have to remember, these are surgically implanted. If a patient gets an infection in their port, the port has to be removed, surgically removed. And then they have a port for a reason, because you don't want to just give chemotherapy peripherally all the time. It's toxic to the veins, it's toxic to the body. So now you've not only them, you also compromise their only way of getting medication, putting them at more risk for another surgical procedure, and then they have to get a new port on the other side for a whole nother surgical procedure because you were too lazy to scrub the hub. That's how fast it happens. Please don't be that nurse. Non-tunneled central catheters. These are catheters placed directly into a large central vein. This is your IJ, internal jugular central catheter. That's going to be your most common. Your second most common is going to be a femoral. And then the third would be subclavian. I did hear along the lines that you had a teacher tell you that femoral lines are like not a thing. That's not true. They happen every day in every single ICU, and they're going to continue happening. Is it the most optimal place? No, of course not. It's in the groin. It's a dirty place. But it is absolutely very, very much common to still occur. So if you were told that, that information is wrong. Okay? Short-term, large volume medications. So this is going to be your PR that are in the ICU that get these central ports. They are at a huge risk for infection, which is why your charge nurses and your managers are constantly going to be asking you if this patient still needs their central line. Do they still need it? Do they still need it? Do they still need it? Yes, they still need it. I'm still giving pressors. I had a patient who got the femoral very much used. Still, he couldn't get an IJ, so they had to do femoral. Yeah. So, what was I going to say? The non-tunneled central catheters usually come with 3 ports, 3 lumens, okay? So when you look at the tubing, the part that actually goes inside the patient, it's about this long, okay? And it starts here and goes all the way into the right atrium, okay? And it has 3 ports. It has a white port, a blue port, and a brown port, okay? Proximal, medial, and distal. And what that means is that at the end of the tubing, there's a hole, okay? In the middle of the tubing, there's a hole. And a little bit farther up, there's another hole. So there's 3 different holes that medications go out of, which is why you can give medications through one port that are not compatible with medications you are giving through another port. Does that make sense? So all compatible medications have to go through one lumen together because they're compatible together. But if I have a TPN over here in my brown port, and I'm not allowed to give anything else with my TPN, I give my TPN in my brown port, I can still give whatever I want in my blue port or my white port, because they come out of the catheter in different spots, so they don't mix. Okay? Makes sense? Complications of IV therapy. I want you to look these up because these pictures kind of suck and they're really small. It's not the pictures, it's that they're really small pictures. So I do want you to be aware of what these things look like. So the first, I'm just going to tell you. So phlebitis, that's inflammation of a vein. One of the hallmark signs of phlebitis is actually a red streak that goes up. It's usually in the arm, that goes up the arm, that follows the track of the vein. Okay. It's like a hallmark sign of phlebitis. Thrombophlebitis is when there's a clot, so thrombo meaning clot, in the catheter or vein that's causing irritation. Okay. Infection, this is going to be at the site of insertion. So you're going to have redness, warmth, purulent drainage, okay? All the signs of infection, a fever, pain, all at the site of insertion. That's the difference between phlebitis and infection when you're looking at it. Infection is at the site of insertion. Infiltration is when a fluid leaks out of the vein into the surrounding tissue. Now, this can be no big deal, or it can be a huge, horrible thing that happens. No big deal is when you go in and your IV has infiltrated and the person's arm is cool to the touch. That's important to know. Cool to the touch, swollen. But there's no real trauma. No, there's no trauma. It's just saline. Okay. But what happens if what was infiltrated is a vesicant? What is a vesicant? Can be chemotherapy.
It can cause tissue death.
Can cause what?
Tissue death.
Tissue death, yes. A vesicant is a drug that causes damage all the way up to death, necrosis, to the surrounding tissue. And that's when we get in serious trouble. That would be called an extravasation. Who do you think we need to call when that happens? Does the provider need notified? Yes. But who do you think has the most immediate answers about an extravasation? Pharmacy. Pharmacy. Yes. Pharmacy. Okay. Air in the tubing or an air embolism. Can air embolism kill? Yes. How much air does it take to kill someone? A lot of air. So when you see your IV beeping because it says air in line and it's just like a little bubbles, that's fine. You need to get the bubbles moving. If it goes into your patient's body, that's okay. It happens every day. I think I looked it up one time and I think it said you need 10 cc's of air to actually kill someone with an air embolism. Three to 5 mLs per kilogram. The lethal dose for humans is considered theoretically between 3 and 5 mLs per kilogram. I swear, if anything ever happened to me and people were like looking up my search history, you'd be like, why is she looking up how to kill people with air? I'm not, I swear. Okay, so I was once told that you would need an entire like IV line of air at one time to actually hurt someone. An air embolism isn't that scary unless it's very, very large. What is scary is a fat embolism. Fat embolisms will kill you very quickly, and those are scary. It's a complication of a BBL. If you ever wanted one, scary. But fat embolisms, they're not capable of dissolving in your blood serum. So they just float around and they block your carbon and oxygen like exchange and can kill you, which is super scary. So, circulatory overload, of course, this is just too much fluid, so hypervolemia. And then pulmonary edema is when the heart cannot compensate and causes that fluid to back up into the lungs, causing pulmonary congestion, fluid in the lungs. And then if you get too much fluid in the lungs, you basically are drowning in your own secretions, which sounds horrid. Questions about complications of IV therapy? It's important that you know the difference of these. Nursing maintenance of IV lines. You always want to reassess your line every 4 hours. You want to flush the site first every single time. Unless you have maintenance fluids running, you have to ensure patency of your line before you give something else. Properly secure the line so it doesn't get ripped out. Educate the patient on their IV site, how to take care of it, don't get it wet, blah, blah. You always want to label with the date and the time. Ensure all lines are properly documented on the insertion and discontinuation. With Epic, it's under the LDA tab where you can add, remove, and chart on the health of your IV line. So the color of your peripheral lines and the uses. So orange is your 14 gauge. These are gigantic needles. Please don't come at me with one of these. Okay. This is for, I've never actually seen in real life. If you're being done by a surgeon with, that's going to, in a trauma situation, a trauma surgeon or a trauma ER physician that is using this type of needle. 16 gauge, again, you're not really going to see these on the floor unless the patient came from the ER or was in a trauma level 1 situation in the OR. But most likely, if you need a line that big, you have a central line, okay? 18 gauge, you can sometimes see these on the floor. There are some nurses that are, you know, they're, oh, I can put 18 gauge in anybody. Okay, buddy, calm down. They're not necessary. I mean, you can do basically everything with a 20 gauge IV, okay? The bigger the needle, the bigger the vein has to be to accommodate it. So you're not going to be putting an 18 gauge needle in somebody's hand. No, like that the vein is not big enough to accommodate for such a large catheter. Okay. This says blood transfusions. Blood transfusions are very adequately safe. Hold on, my husband's calling me. Hello? Yes. What's that? Are you okay? Okay, I'll wear it. That's right. I look. Are you in the middle of lecture? Yes. Yes, I am. Are you alive? Is everything okay? Anyways, okay. So, one thing that I really, really, really need you to know about this is that you have to have at least a 20 gauge IV to give blood and to give IV contrast. You have to have at least a 20 gauge IV. If you go any smaller, specifically for blood products, it will cause cell lysis, which means destruction of the cells. It will shred the red blood cells. And the whole point of a blood transfusion is to give red blood cells, right? So you don't want to destroy them by giving them through a teeny tiny catheter because they can't fit through them. They just get demolished. So you have to have at least a 20 gauge IV for blood products. IV contrast is given very quick. If you've ever had IV contrast, you know that there's a machine that like pushes it fast, quickly inside of your body. Anything smaller than a 20 gauge is not adequate enough for that pressure. Okay, so it has to be at least as big as a 20 gauge IV. A 22, you really, you can use a 22 in the hospital, especially if it's an older person, a person that has very small, fragile veins. But I would definitely make sure that patient doesn't have a CT scan ordered with contrast, because the first question that CT tech is going to ask you is what size IV they have. And if they don't have a 20 gauge, that patient's not getting a CT because they have to have one in order to get this VA contrast. 24 is really, you should never be using a 24 gauge in a hospital on an adult. No. If you're having that much of an issue getting an IV site, call the IV team. Okay. Some of us are really, really good at IVs. Some nurses are amazing nurses and suck at IVs. It just is what it is. Okay. So if you are a person that isn't super great at IVs, call somebody else to help you. Because the more you poke someone, the more pissed off they get and the more they want to call patient advocate. Okay, that's never good. And a 26 gauge, you're only ever going to really see in a NICU. I don't even know if even at children's in the OR, we didn't even see these in the OR. They were only in NICU patients. Okay. Any questions about IV size, gauge, and what they're used for? Okay. Okay. Hypovolemia versus hypervolemia. Hypovolemia basically is dehydration. There can be a lot of different levels of dehydration. Okay, levels of hypovolemia. All the way from mild dehydration all the way to hypovolemic shock, where you're literally dying because of how much fluid you don't have. Okay. There are multiple systemic signs and symptoms when you're hypovolemic, tachycardia. At first, you're going to have hypertension because your body is going to try to compensate. The more fluid you lose, the less compensation you have, the lower your blood pressure will become. Excuse me. Treatment usually consists of isotonic or hypotonic IV solutions. When we give fluids, we need to monitor fluid balance, I's and O's, renal function, listen to the lungs, and perform frequent vital signs. Because when someone reaches a level of shock, even if it's from hypovolemia, you can only give fluids so fast before the heart can't compensate and you drown them, literally drown them. So you have to be very careful, and they may require pressors at the same time to increase their blood pressure while you are fluid resuscitating them. Okay. If you have an 80-year-old grandma in hypovolemic shock that has a history of heart failure, you're not bolusing her with 5 liters of fluid to correct her hypovolemia. You will kill her. Okay. So this is a very fine balance that is given to you by the direction of a very educated physician. Not my choice. Hypervolemia is too much fluid circulating and the body can't compensate for it. The symptoms include edema, JVD, which is your distended neck veins, jugular venous distension, crackles in the lungs, tachycardia because of the increased volume, increased workload on the heart, and increased blood pressure because there's just so much fluid. Treatment includes diuresis and fluid, and fluid and sodium restriction. And then fluid and sodium restriction. Nursing care, of course, daily weights and assessment of edema and whether or not that edema is getting worse. Before we get into electrolytes, any questions on hypo versus hypervolemia? That is sodium. This is natremia, Na. Na, or sodium, is a positive ion. Normal levels are apparently 136 to 145. And it balances our fluid volume, blood volume, and regulates nerve impulses. What is one of the first signs of a sodium imbalance?
Polyuria?
Sweating?
One of the first
Confusion?
signs of a say that again?
Confusion?
Confusion. Yes. One of the first signs of hyper or hyponatremia is confusion. What is a very scary complication that can happen with a sodium imbalance that you need to place precautions for?
Seizures.
Seizures. We need seizure precautions. And what happens if our sodium does not get fixed and it keeps getting worse?
Maybe a coma.
Coma. And then what?
Death.
Brain death.
Cardiac.
So each one of these have little remember things. This one says salt loss. The one thing it doesn't have, which if I could make this myself, then like I said, the very number one thing that you're going to see is confusion. I'll never forget in a million years. This was 10 years ago or more. I was a tech on 7 West in Boardman at St. E's. And I had a patient that had just gotten a hip replacement. I don't even know if I was in nursing school yet, to be honest with you. And I walked in her room and helped her to the bathroom. And she was a very nice older lady. She was just saying really odd things that didn't make any sense. But then I was in nursing school because I did ask her orientation. I asked her orientation and she answered all of the questions correctly. But I didn't know, I wasn't a nurse yet. I didn't know what was happening or what I was looking for. I just knew that she was responding really odd. I don't remember exactly the things that she said, but it just made you look at her and be like, huh? But then she knew her name, she knew where she was, she knew the year, she knew the president. She was oriented in every single way. So I go out to the nurse's station and I go to the nurse, her name was Kristen. And I said, hey, I just want to let you know that this patient is just really odd. Like she's just saying really weird things. And it seems like she's really confused, but she's completely oriented. And the nurse totally brushed me off. And she was like, okay, yeah, whatever. Well, an hour later, the nurse goes in there and she notices that there's something wrong with this patient. And they end up calling an RRT and her sodium was 117. And she comes back at me and she's like, why didn't you tell me that there was something wrong with her and blah, blah, blah. I said, excuse me, ma'am. I 100% told you that something was wrong with that patient. I told you she was confused. I told you she was weird. I'm not a nurse. I don't know how to put that into words for your nurse brain to understand what I'm saying. But I'm telling you, I told you that something was wrong with that patient. And you chose to not go see that patient and investigate on your own. That's on you. That's not on me. Okay? Which is a very good lesson into listening to your techs, because they may not be able to give you all of the information wrapped in a nice bow, but they are your eyes and ears when you're not in that room. And they 100% know when there's something off with a patient. Okay? Don't brush them off. So that was, I'll never forget it. I'll never forget how odd the confusion was and how she was still oriented. And we ended up transferring her to the ICU because she had a sodium of 117. Like she could have seized at any moment. And that becomes very dangerous. So anyway, you have your little acronym. It's SALT loss. Like I said, every one of these are going to have a little acronym for you to help remember the signs and symptoms. So stupor, coma, anorexia, nausea, vomiting, lethargy, tendon reflexes are decreased. Limp muscles like weakness, orthostatic hypotension, seizures, headaches, stomach cramping. The causes of this can be dilutional hyponatremia. So if your patient has an excessive amount of fluid volume, they're hypervolemic, they may have a normal amount of sodium, but all the fluid that's in their body, yes, we are. All the fluid that's in their body is diluting their salt. Okay? That's what we call dilutional hyponatremia. So when you remove the fluid, you end up with a normal sodium level. So when you have dilutional hyponatremia, you don't want to just dump salt into them. You wouldn't want to give them a hypertonic solution, because when they normalize and that excess water gets removed, they're going to be hypernatremic. Okay? So you have to look at what's causing the hyponatremia. So is it CHF with fluid overload? Is it too much hypotonic fluid, which is causing a fluid shift, causing them to be hyponatremic? Liver failure, excessive water intake. Could it be that they're just not getting enough sodium? They have anorexia. They're NPO for a procedure. Are they losing too much sodium? That's being caused by a diuretic. specifically a loop or thiazide diuretic? Do they have excessive diarrhea or vomiting? Dehydration that is caused by excessive sweating. When you sweat, you lose a lot of sodium through your sweat. And then NG suctioning, which is suctioning all of your electrolytes out of your stomach. Okay. The treatment, if it's due to hypovolemia, you need to give a sodium chloride infusion. If it's due to hypervolemia, we need to get the excess fluid off with diuresis. If it's due to excessive water intake, then we need to have a fluid restriction and educate the patient on what they're doing. The nurse in the making book includes SIADH in the causes, making it 5Ds. I agree. Hyponatremia is a symptom of SIADH, which is symptom of inappropriate antidiuretic hormone. Nursing care, we want to assess the mental status to monitor the change in the level of consciousness. Safety precautions, because obviously this patient is at a huge risk for falls because of the seizures, because of the confusion. You want to make sure your bed alarm is on and their call light is with them. Okay. We're going to do hypernatremia and then we're going to go over math. So hypernatremia, they have the acronym of fried salt. So you have flushed skin and a low-grade fever, restless, irritable, anxious, confused, increased blood pressure and fluid retention, because wherever there's salt, there's water. Water follows salt. The more salt you have, the more water you have. The more salt and water you have, the higher your blood pressure is. Okay? And pitting. So you can have generalized edema that's non-pitting, and you can have pitting edema. That doesn't mean they're not both edema. Decreased urine output and a dry mouth, because the sodium in your body is keeping the water in your body. Okay? So this is going to cause you to want more water because your mouth is dry. Flesh skin, agitation, low-grade fever, which is already up there, and increased thirst. The cause is from excessive intake, so too much salty food or hypertonic solutions, like a 3% saline. Loss of fluids like diarrhea, diabetes insipidus, excessive sweating, which I don't know why excessive sweating is on there. Because it said sweating for, I guess if you sweat and your body retains the sodium? I don't know, but usually sodium comes out in the sweat, so I don't really know how that leads to hypernatremia. Anyways, decreased sodium excretion from kidney disease and dysfunction. Burns do cause a lot of fluid loss. But you would see hyponatremia, not hyper. The treatment, if due to excessive intake, is to restrict sodium intake, educate the patient on a diet, and or change and stop the IV fluid. So if it's caused by hypertonic IV solution, you better stop it before you kill your patient. How does diarrhea cause hyper? Diarrhea causes hypernatremia because it causes, so we just talked about dilutional hyponatremia. Well, there's also concentrated dehydration. So when you dehydrate something and you don't lose sodium in your stool, okay, you lose sodium in your urine. So if you're losing a lot of fluid through your stool, diarrhea is also in hypo, right? That's a great point. I'm going to look that up. That's a good question. I'm going to look that up. But specifically for loss of fluids, if you're losing all of the fluid in your stool and you're becoming extremely dehydrated, then you have what's called concentration. So obviously it's the opposite of dilution. So you take all the water away, but all of your salt remains, then your serum is going to say that you're hypernatremic, but really you need fluids to balance yourself back out. Does that make sense? Okay. I'm going to answer your question in 2 seconds. Chronic severe vomiting or diarrhea and other causes of dehydration. This causes your body to lose electrolytes such as sodium and also increases your antidiuretic hormone levels. So vomiting can cause hyponatremia because of the loss of fluid that can contain sodium. Diarrhea is the most common GI cause of hypernatremia because of the loss of water in excess. Raise your serum sodium. So it seems with hyponatremia, it's more of a chronic issue that causes the body to lose electrolytes such as sodium and also increases your antidiuretic hormone, which is ADH. With hypernatremia, that is an acute issue. So when you acutely lose a large amount of fluid in the stool, it causes concentration of your serum. Does that make sense? If due to volume loss, you need to administer IV fluids, and this is where your concentration comes in. If it's due to the fluid loss, you need fluids to replenish. And then if due to inadequate renal excretion, administer diuretics that promote sodium loss, which include loop and thiazides. Okay. Wednesday, we'll start with potassium. It can cause both, but there are different ways. The causes are different. Okay. Getting there. Oh my god, you guys are so quiet. It's killing me. I feel like I've just left. I feel like I'm alone in a room. I'm so not kidding. Erase all the answers. Okay. All right, well, now I need to log on to Rig Central. Okay. Can you hear me?
Yes.
Yeah.
Yes.
Okay. Can you?
Yes.
All right. Okay, so a nurse is preparing to administer 0.9% sodium chloride, 850 mLs IV to a or to infuse over 2.5 hours. The nurse should set the IV pump to deliver how many mLs per hour?
Is it 425?
I don't know. We're doing the maths together, girlfriend.
Okay.
I got 340.
She only did 2 hours. 2.5.
It's 2.5 hours.
Yep, I see that now.
Everybody get 340?
Yes.
Yes.
Yeah.
All right, number 2. A nurse is preparing to administer LR 300 mLs to infuse over 15 minutes. The nurse should set the IV pump to deliver how many mLs per hour? How many 15-minute intervals or increments are in an hour?
0.25.
4. There's 4 15 minutes in an hour. Okay? So you have to deliver it 4 times as fast okay, for it to deliver that fast. So
I'm confused.
I know, hold on.
Would you have to do like what 60 divided by 15, and then you would do 300 divided by that? Is
You
that how
don't
do it?
divide anything.
No.
This is all multiplication.
Right, but when you have to, well, I guess if you didn't know how many 15-minute increments was in 60, when you need to divide that by 60? If somebody just didn't know that off that.
So I usually will preach dimensional analysis all day. All day. But in these very specific situations, the very easiest way to find the answer is to figure out how many times 15 is in an hour. So say this question was 30 minutes. I'm delivering it over 30 minutes. There's two 30-minute increments. I'm going to multiply the amount by 2. So in order for me to give 300 mLs per hour in 30 minutes, which is half of the hour, I'm going to multiply it by 2. I could also do 300 divided by 0.5, which would give me 600. So in order to do this in dimensional analysis, you need to give me what is the decimal of 15 minutes in 60 minutes. So 15 over 60. What is this in a decimal? That's a quarter hour, right? So 300 divided by 0.25 is what? And if you did it the other way, 300 times 4, because there's 4 15-minute increments, it's 1,200. Now, it's only really helpful if the question, trying to erase you, erase. Where aren't you erasing? So what if it said you wanted to deliver it over 34 minutes? How would you figure that out?
I think the easiest way is just to convert and then just do.
To a decimal, I agree.
Yeah. And then do the mLs over the hours.
This seriously will not let me erase. Okay. So does everybody understand how we got that answer?
Yes.
So no matter what the minute is, it's how much does it take up of the 60 minutes? So if this was 34 minutes out of 60, what is that in a decimal? Yes. We rounded it to the 10th, it'd be 0.6. And then it'd be 300 divided by 0.6. Equal 500. So no matter what the minute is, you have to find out the decimal out of 60 minutes. Just like when you're doing weights and you have ounces and you have to convert the ounces to be able to find the kilograms, it's the same idea because it's a fraction that you have to make a decimal. Does that make sense? How do we feel about that? Because I feel like these are the questions that people struggle the most with. Somebody talk to me. I can't just keep talking to myself.
Was that the right answer if you change the minutes to 34?
So it depends on if you round in the middle of the answer, which you really should never round in the middle of an answer. But I was just trying
To be honest, that's why I was confused. When we rounded in the middle, the directions say not to. So that's why I didn't want to say anything, but that's why I was confused.
No, you're fine. My point was not to confuse you. My point was to say that it doesn't matter what the number is, whether it's 15, whether it's 32, whether it's 48. The whole point is that you have to convert it into a decimal for dimensional analysis to work, to divide in any way. Okay? So if this was 45 minutes, they wanted you to deliver 30 mLs over 45 minutes, you could do 30 times or 300 times, well, you would have to convert. So it'd be 300 divided by 0.45.
I set mine up different for dimensional analysis. I don't do decimals at all, but I got the same answers that you did.
Same.
Set it up.
So I do mine like 300 mLs over 15 minutes times 60 minutes per hour. And then I do it like that. So it's 300 times 60 divided by 15.
There you go. There you go. I like that.
Yes.
Well, I just gave you 3 different ways to find the same answer. Choose which one makes the most sense to you. So now let's do the 33 minutes. Was it 33 or 34?
34.
Ooh, 18,000. 529.41, which would be 529.4. Yep. So does that make more sense? And how we got there?
Yes. So much more.
Beautiful. Perfect. All right. A nurse is preparing to administer dopamine 4 mics per kilogram per minute by continuous IV infusion for a client who weighs 150 pounds. This is just like the question we just did, Chelsea. This is a question that very closely resembles one on your ATI module. Available is dopamine 400 milligrams and 250 mLs. The nurse should set the IV pump to deliver how many mLs per hour. So me specifically, I like to figure out my kilograms outside of the question. You can build it into your dimensional analysis. Which one would you prefer and which one do you do? Do you build it in or do you do it outside?
Build
Outside.
it
Outside.
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 Okay, so 150 divided by 2.2. See, and this is where you get in trouble. Because if you do it in this specific question, if you do it outside of the problem, it has a very long decimal of 68.181818181818, okay? Which is why you need to, in this situation, you would have to do it together because you can't round your weight in the middle of a problem. Okay?
Yeah, see, that's what the problem was last class. You rounded it. One person was telling us to round it at a certain point and only use 2 decimals. Somebody else said use 1 decimal, so it was giving us the wrong answer. And depending on where you rounded that weight, when you put it into kilograms, is dependent on the answer you got. So, like, some people were getting one answer and somebody was getting another answer, but it was because of where they rounded the weight.
Yeah, and that's kind of my problem with the last problem we did, because I just redid it and we didn't get 529.4. We got 600 because we rounded in the middle. We got not 600, 500 because we rounded in the middle of the problem for our answer. But when you went back and did it the dimensional analysis way, we got 529.4.
Which is why you should always follow the rule that you never round in the middle of a question.
Okay.
I feel like that was in the PEDS class. Am I right?
PEDS is just different. PEDS is all right. We only have like 10 more minutes. So we have so this is milligrams to micrograms. I recommend converting to micrograms. I feel like that's going to be better. So
0.4.
no. It'd be 400,000. Micrograms to, or milligrams to micrograms.
Oh, okay, I see.
I need to do that the other way around. I hate this. This did not give me this much trouble last month.
Wait, I thought that if you know what? Never mind, because that's 400 milligrams. Okay, I'm tripping. Never mind.
So anytime we're going from like a larger number to a smaller number, the number would be larger. Like, because we're going from milligrams, which is large, to micrograms, which is really small. So the number would be larger then, right?
Yes.
Okay, thank you.
Okay, sorry. Okay, so let's see if I screwed this up. So you're gonna see me do something that when you have really big numbers, and you have a lot of zeros, it makes really big numbers lead to mistakes. Okay. So something that I do, and if you choose to do, I want you to be very, very careful when you do it, okay, is cross out zeros. And you can only do that from the top to the bottom. So if I take a zero from the top, I have to take a zero from the bottom. If I take a zero from the top, I have to take a zero from the bottom. If I take a zero from the top, I have to take one from the bottom. So I have 1, 2, 3 zeros on top, and I took 1, 2, 3 zeros on bottom. They have to match each other. Okay? So when I do that, it makes my numbers a lot more manageable by 25 times 4 times 1 times 15 times 6 or 400 2. Do you see how that makes things a little bit more manageable? But I don't want you to do it if it confuses you. The only reason I'm saying it is because I know that black little calculators are junk and they will only hold so many numbers. And I've watched people get the wrong answers because there's just so many zeros. And those little crappy calculators can't handle all of those numbers.
Can I ask a quick question?
Yeah.
So for me, I feel like all these steps lead to mistakes for me. And I'm not sure if you answered already, but can we do the 4 micrograms and find it by kilograms first so there's not so many things to fill out? Does that make sense?
So the problem with that is that the 150 pounds to kilograms is 60, what was it, like 68.181818182.
Yeah.
And you can't round in the middle of a question.
Okay. Yeah, okay, I heard you say that. I think my brain was still trying to figure something out.
Even though you can't round it once you do that conversion, I mean, if you go all the way to the end of the problem, will it still give you the same answer if she do it the way that she just said?
Say that again, I'm sorry.
The way that whoever just asked about doing the 4
Conversion
microgram,
outside.
yeah, doing that, even though it gives you that number, if you still go all the way to the end and round, will it still give you the same answer?
If you round the weight in the middle, it will not give you the same answer.
No, I'm not saying round in the middle. I'm saying get your weight, complete the problem, and then round at the end as you normally would have to. Will that still give you the same answer? I'm not saying round in the middle of the problem.
I don't think I understand
everything on
Okay.
the calculator, not rounding, just from there, doing the weight, and then doing the rest of the problem in the calculator.
Oh. Oh, okay. So like if you were to say, if you have your calculator in front of you and you have 150 divided by 2.2 and it gives you the answer, right? And you know where it falls in your problem. I wouldn't recommend doing that unless you knew, like you wrote your problem out. You know exactly where everything goes, right? So yeah, you have your weight right here, and then you can multiply 250, 60, 68 point blah, blah, blah is in my calculator times 250 times 4. And then I wouldn't need this whole middle part because I already converted times 60, which would give me a number over 4 million, by the way, which is why I cancel out zeros. So I'm going to do 150 divided by 2.2 times 25 times 4 times 6. So that gives me 49,909, blah, blah, blah. And then I'm going to divide by 880. No, that did not give me the same answer. I must have screwed it up somehow. I must have forgotten something. So I hear what you're saying. I finally do understand what you're saying, but I do feel like for me, especially because I just did it, it screwed me up. I don't know. It didn't work for me.
You have to know exactly how to do the steps.
Yeah, you would have to know every single step in order to go out of out of order.
If I don't take out any zeros and do it from the weight, then 50 divided by 2.2, keep all the decimals. Multiply that by the 250, by the 4, by the 60, and divide it by 400,000, it gives me 10.22.
Oh, because I divided it by 880 like a dummy. I forgot to take out the 2.2. So it would have worked. Yeah. And that's what I'm saying. If you would have to be very like precise in what you're doing. Because I forgot to take out the 2.2. I took out this whole part, but then when I got down here, I kept this the same instead of taking that out. So yes, it would have worked if I would have not made a mistake.
I guess 7, 7, 7, 7, 30.
All right. It's 2:30. If you have to go, you can go. If not, I'm gonna keep going. So a provider prescribes magnesium sulfate 1.5 grams per hour by continuous IV infusion. Available is 2,000 milligrams in 100 mLs. Determine how many milliliters per hour. So we need to go from grams to milligrams.
Miss Simmons.
Yeah.
I do have to hop off. Is there any way that we can get like a practice math sheet sent to us? And then
You
maybe
have module.
Yes, but
I
see,
know.
that model is so confusing.
Yeah.
But I mean, that's like if I gave you another practice worksheet, you still have to do your module with and the quiz is what, 25 questions on the module?
Yeah, something like that.
So that's, I mean, that's 25 math questions right there that this test is based off of. You know what I mean? So what is 1.5 grams to milligrams?
$1,500 milligrams.
Okay. So I'm going to show you how cool it actually is to cancel out zeros. Oop.
But if you cancel them out, wouldn't you have to add something back in eventually?
No, you never have to. No. Because think about it like fractions. When you simplify a fraction, you never have to add anything back in. It's just simply simplifying a fraction. So theoretically, all I'm doing is simplifying a fraction. Now, we don't have to do it like this. It can be 100 times 1500 divided by 2000.
That makes more sense to me.
And that's fine. I want you to do whatever makes sense to you. The reason I'm showing you this is because I know in the past that I have had a couple students that failed their math test because the numbers got so big that their calculator, that little black calculator, screwed up and they couldn't get the right answer because it couldn't hold all those zeros. That's the only reason I'm doing this. Because I want you to be able to use it if you have to.
Even like I have trouble writing out the since it confuses me. I have to look at the problem and try to break it down in my head of the steps how to do it. Just do it.
Jeez.
Writing that out, I get them all jumbled.
So the thing with dimensional analysis is it can only go one way. Ever. It can only always go one way. So if I'm always going to start my problem with what I have, with what I'm looking for. So I'm looking for MLs, so I'm going to start with MLs. What is equal to my MLs? These guys go together. This goes together. They're buddies. I can't separate them. So 100 mLs has to go with 2000 milligrams. Now, whatever I have down here has to match what's up here. That's the rule. So what else do I have in my problem? I have grams over 1 hour. Well, I already know I have to convert my grams to milligrams. And I know we've already found out that it's 1500 milligrams over 1 hour. And now I have nothing left in my question. So I have milligrams here and milligrams here that crosses each other out. What I'm left with is milliliters per hour. The only way dimensional analysis works is if at the beginning you start with what you're looking for, which is mLs, and at the end, you end with what you're looking for. You have to start with what you're looking for and end with what you're looking for, and then cross out everything else in between. Because if you do it any other way, it will not make sense. Does that make any sense?
Yeah.
So a nurse is preparing to administer 9 mics per minute of epinephrine. Available is epi 1 milligram in D5W 250 mLs. So these guys go together. These guys go together. And I'm looking for milliliters per hour. So I have 250 mLs. And who's my buddy? My 1 milligram. But am I going milligram or am I doing microgram? Okay. So what is 1 milligram equal to how many micrograms?
1,000.
And then this is my guy that matches. So I have to put my guy that matches right here. And then who's my buddy? 1 minute. But I can't stop there because it's asking for hours. I have to end with what I'm asking for. So my minute crosses out my minute, my micrograms cross out my microgram, and all I have left is milliliters over hours. Does that help at all? Yeah. What just happened? Did everybody get 135? I agree.
Yes.
We're not even allowed to like buy a good calculator and bring it in.
So I actually did have a student that did that. She brought her own calculator because she was screwed over by the black calculator so many times. She brought it to me in the original package, and I did let her use it for the exam. She brought it to me in the original package. Was I allowed to do that? I don't know. That was months ago. And if I probably said that in front of Dr. Bowling, she'd probably rip my face off. So, I agree. The calculators are trash. All right. A nurse is preparing to administer heparin 18 units per kilogram per hour by continuous IV infusion for a client who weighs 68 kilograms. Available is heparin 25,000 units in 500 mLs of sodium chloride. So this is my buddy. This is my buddy. Oop, units. They were nice enough to already give us kilograms. Oops, I'm sorry. No. Come on, Jessica. I was right the first time. That's fine. You can go. I'm not holding you, I promise. Only stay if you can.
Just like our calculators. It's bigger.
It's desktop. I hear you, girl. Okay, did everybody get 24.5?
Yes.
Yeah.
What almost tripped me up was I was gonna convert, but they already did all the converting for us. So
Yes. You didn't have to do 60 minutes because it was already per hour. And you didn't have to do kilograms because they already gave us kilograms. So absolutely, you can 100% totally screw yourself if you don't realize that that says hours instead of minutes.
Right.
All right, almost done. A nurse is preparing to administer lidocaine 3.5 milligrams per minute by continuous IV infusion. Available is lidocaine 1,000 milligrams in D5 water, D5W 250. So these are my friends here. These are my buddies. Did everybody get 52.5?
Yes.
Is anybody still working? All right, a provider increases the rate of lidocaine to 6.5 milligrams per minute. Available is lidocaine 1,000 milligrams in 250 mLs. I will say, if you're not going to stay for the last one, please watch it so that you get it, you don't fall into the trap. Okay, so just make sure you watch the last one if you're leaving. And tell your friends too.
So you're recording.
Yes.
Perfect.
Perfect. A provider increases the rate of, oh, I already read it. Okay, so. This is basically the same question as the last one. I ever tell you I'm dyslexic with numbers? And you just watched it happen to me. All right, last one.
So was that one of those like titrating? Oh no, this is the titration one, kind of.
This is the
I feel like
titration one.
okay, because that one I feel like they kind of, I mean, they titrated it up for that last one because it was the same thing, right?
Oh, was it? Oh yeah,
Yeah,
it
because it's
was.
saying that they increased it.
That's what I was like, this looks like the same question. I didn't even realize it was the same question. That's funny. Okay, so this is basically the same exact thing. It's just all in one question and it's worth 2 points. Okay, so if you miss this whole question, you fail the test. So a nurse is preparing to administer Esmolol, 75 mics per kilogram per minute. The client weighs 88 kilograms. And available, you have 20 milligrams in 250 mLs. Okay. So I have 250 mLs for 2,500 milligrams. So do you think we should convert from micrograms to milligrams or milligrams to micrograms?
Would it be micrograms to milligrams?
Okay. So how many milligrams is 75 micrograms. I feel like I would do it the other way around.
Yeah, let's work with the microgram.
So I would make the 2,500 milligrams into micrograms, which would be 2.5. Right?
Yeah, that would be like 2.5 or 2,500,000. Yeah.
Yeah, it wouldn't be 2.5. It'd be the other way around. Ugh, I hate that.
Yeah, that's big.
Either way,
That
it sucks.
calculator isn't gonna.
Exactly. Either way, it sucks. And that's how the people that I'm telling you about that I taught how to cancel their zeros, they literally failed this exam because of this last question and because of the zeros. So let's do the 2,500 milligrams. And then what was the mics? It would be 75.
It would be like
micrograms.
0.075.
Yeah. Let's see if this helps with our zero situation. Per 1 kilogram, Jesus, times 88 kilograms over 1 minute times 60 minutes over 1 hour.
Brightspace, ain't it?
Huh?
Is this sheet on Brightspace?
No, this sheet is not on Brightspace. Okay, so if you say to yourself, well, wait a second, I can just double this. I'm telling you that I don't know if I don't remember which exam it is, but if you double it, and I don't remember if it's the first or second, you will get it wrong because of the rounding. Okay? So please pay attention and actually do the second problem because you may really screw yourself. All right? So 250 mLs over 2,500 milligrams times what would it be? 150, so 0.15 milligrams over 1 kilogram times 88. And this one, it does give you 79.2. But I'm telling you, please remember that one of these tests, if you double it, you will get it wrong. So please, please, please double check your answers. Okay? All right. I'm sorry I went over.
No, thank you so much for that.
Yeah, thank you
You're
for
welcome.
doing that.
You're very welcome. I have noticed specifically what?
Is it only 9 questions on the test?
Yes, because the last question is worth 2 points.
And
Oh,
what
okay.
did you get
All
for the
right.
last one?
The last one is 79.2. I'm still confused by the
Okay,
last
great.
one. Christina, why are you confused by the last one?
I don't know, like when I plugged it in, I got a completely different answer.
For
I
A
went
or
with the
B?
big numbers.
Both.
For both?
Yeah, because like my answer for A was wrong. So then
Okay, so let's figure out where you went wrong. So what did you get for A?
hold on. It was like 0.002 something.
Well, it sounds like your conversion was wrong then. Something had to have been off.
Mm-hmm.
Or you forgot a number or something.
Let me try to plug it in again.
Okay.
I just had a quick question about the code you sent out for the books. The second
Yes.
code, I can't get it to go. And is it going into the same book, the medical search?
It's one code is for the med surge and the other code is
The
for the
VSIM
VSIM
book,
book.
okay. Because I tried that one, the second.
Did you get Hold on. Did you get the book code for your VSIM book yet?
Yes.
Okay.
So the
So
second
the-
code goes into for the VSIM.
Yes, that's the course code
Okay.
for the VSIM book.
Okay, perfect. Thank you.
Mm-hmm. Christina, where you at, girl?
Okay, I'm about to I just finished like putting it out in dimensional analysis, so now I'm gonna put it into my calculator.
Okay.
So when I multiply everything at the top, I get 1,125,000. And then
Can you see my screen?
uh-huh.
So what's the difference between your screen and my screen?
Well, like I
wish I could
put
see your
everything
screen.
I put everything in the dimensional analysis. Like I don't convert outside of it. Like I put the conversions, like I work that out in the same.
Okay. Okay.
Do you want me to turn my screen on? You can see what I wrote.
Are you like on a laptop or I mean like an iPad or something?
A laptop.
And you're like writing on your screen like I am?
No, like I can hold up my piece of paper to the camera.
Oh no, it's really hard to see it like that.
Okay.
I've tried. I hate the way that this is doing this right now. It's so annoying. Okay, so you're converting everything in your problem.
Yeah, but I see I just
you
messed up with
have-
one of them. I added pounds, but it's already converted, so I can take that out.
Yeah, so you have 250 mLs per 2,500 milligrams
times 1 milligram is equal to 1,000 micrograms times 70 micrograms times 1 kilogram times 88 kilograms over 1 minute times 60 minutes over 1 hour, right?
Let me just double check that. Hold on. Oh, I have my 88 at the bottom.
Your 88 has to be on top.
Okay, wait a minute. Okay, give me another second because I gotta rewrite it out.
Okay. Did anybody else do it this way? Do you convert? Because there are a lot of people, they convert everything in their problem.
Okay. All right. Now let me plug this in. So yeah, I see why you did yours like that. That makes sense. So for the top, I got 99 million.
Yeah. Yeah, because then you would divide by, you're not dividing by 2,500, you're dividing by, what, 25,000?
Wait. Wait a minute. It'd be 25. 25. How do you say that? 2,500,000?
Oh. What is it? 2,500 times 1,000. Yeah, would be 2,500,000. Sorry. And this is what I'm talking about. Those little black calculators, they can't handle this type of math. There's too many zeros. And this is exactly why we're going over this. Because I've watched people fail this test because of the large numbers.
So then how we're supposed to do it if you know some of us do it like this?
I'm going to show you. I'm going to show you. And you have to pay attention because you specifically, because you do all of this written out, you specifically have to pay attention to what I'm doing. Okay. So when you cancel out zeros, whatever you do to the top, you have to do to the bottom. So in the first question, in part A, I only have how many zeros on top?
2.
2. 1 here, 1 here, which means I have to take away 2 zeros from the bottom. So I'm going to do it from the 2,500. Okay. So that helps make my math smaller so that my calculator doesn't get all jumbled up. So that means it's 25 times 75 times 88 times 6, which gives me 990,000 instead of, what did you have? 900 million?
It was 99 million.
99 million. That number is not capable of going on that calculator. So then on the bottom, I have 25 times 1,000, which is 25,000. So 990,000 divided by 25,000 equals 39.6.
Okay.
Does that make sense?
And then it does. And then how do you work that into B?
So in B, how many zeros do I have on top?
1?
I have 3. I
What?
have 1, 2, 3.
Oh, you have to redo the whole problem again, but then
I mean, you wouldn't, I just wrote it back out. You know what I mean? It's the same problem. I mean, the only thing you're changing is this number for this from this number to that number. I just wrote it out again.
Okay, so we
help
don't
you
have
guys.
to put in that 39.6 that has nothing to do with B?
No, that has nothing to do with B at all.
Oh. Okay, I get it now. I get it.
So I crossed out 3 zeros on top, and I'm going to cross out 3 zeros on bottom.
Okay.
So
Got you.
25 times 15 times 88 times 6 is 198,000. And 25 times 100 is 2,500. And that's going to give me 79.2.
Okay. Thank you for going over that again.
You're welcome.
Have
That
a good
makes
day.
sense?
Yes, it does.
Okay. All right. Have a wonderful day. All right. Does anybody
Thank
have
you.
any other questions?
I don't. Thank you.
Okay. You're welcome.